Yes. Yes, sir. Now you can start.
Good afternoon, everyone. So we are here from ICOG to have our Odyssey of Teachers. This is a FOGSI ICOG series of online learning methods. And as a teacher, we are always evolving and trying to learn new learning teaching methods. Students don't need a perfect teacher. They need a happy teacher who is going to make them excited to come to the platform or to the college or to any learning school and grow a love for learning. So with this objective, we have to see that our students are eager to learn, and we have to have new learning methods so that they keep their interest in the subject. So let us embark on this lifelong journey of educating ourselves with a plethora of new student-centered interactive teaching learning methods which shall allow the students to actively participate in the process of learning. So with all these objectives, ICOG has started this program of Odyssey of Teachers. And today we are having fourth module of Odyssey of Teachers in the form of where we will be focusing on drills and simulation based learning. So if we show them by doing some action, probably that will be a very easy method to understand and to learn. So before we start, we have our ICOG chairperson, Dr. Sheila Mane, with us, and I request her to say a few words.
Good afternoon, everybody. I think it is, I feel it's my proud privilege now to be associated with this program. And as all of us are teachers, I think this becomes a very important component of our curriculum. And I'm so happy and thankful to Dr. Ashok Kumar, Dr. Vandana, and Dr. Vidya Thobi for taking up this initiative of Odyssey of Teachers. Because we also have now institutes where they have DNB, and the most of the teachers there are clinicians, and it will be close the door. It will be good to see that all are well versed with the teaching method, and that will definitely help the students as well as the teachers. I think there is a very big galaxy of teachers today who are going to participate, and today the module is, I think, on the drills and the simulation based learning, and that is on a very important topics like PPH, eclampsia, shoulder dystocia, and obstetric collapse. And I think if we have to really strengthen our system, so unless and until the people are trained properly, and if we regularly conduct this, definitely it will help to strengthen the system, and that will help to save the mothers, to reduce not only the mortality but I think the morbidity also. So bringing awareness of the prompt treatment and the golden hour, I think the students will learn through this, and I'm thankful to all the teachers. There is a big list, so but I thank everybody for participating in this module, and looking forward for your association with ICOG in future too. And it's very nice that next year also it's going to be Dr. Ashok Kumar, but all of us will be together and we will continue to grow together. Thank you. Thank you very much.
Thank you, madam. So before we proceed further, I take this opportunity to thank our FOGSI president, Dr. Bhaskar Paul also, and Secretary General, Dr. Suvarna Khadilkar, and obviously Dr. Sheila Mane madam for supporting us in continuation of these program. And under their leadership, ICOG will grow further and further. I welcome all of you, all the faculty, all teachers who have joined us in today's deliberation, and all the faculty members and the teachers from medical colleges who have prepared their videos and to demonstrate the drills and simulation based learning. So thank you from ICOG for your commitment and your time you have devoted for the activity of ICOG. So this simulation-based learning is a student-centered active teaching method which allows dynamic learning with long-term knowledge retention. It is an integration with the traditional teaching method. It can empower students and build their confidence to face real-life clinical scenarios. Simulation and practice of drills permit the retrieval of clinical skills through intended practice rather than an apprentice style of learning. Team-based simulation training has been shown to improve not only technical management of emergencies, but also communication and teamwork, which are critical for patient safety. The implementation of simulation training alongside the traditional lectures has shown to reduce errors and improve performance of medical procedures. Practicing regular drills broadens students' thinking through creative new approaches and strengthens the professional expertise by developing skill, competency, and leadership qualities. So in this module, we shall demonstrate the use of drills and simulation in teaching the skills and knowledge necessary in managing 4 different obstetric emergencies. And we are mainly focusing on the methodology. Please try to understand, we are not here to teach you or to give you how to manage PPH or how to manage shoulder dystocia or how to manage eclampsia and cord collapse. These are the 4 drills we are going to do. But you try to understand the mechanism or the methodology which is being adopted to convey these topics to the students. So please, if there's some error in our theory or some error in our scientific knowledge which we will be providing you, we are not here to discuss that. Please try to focus on the methods, this teaching method or this learning method which we are going to demonstrate. So please be focused on that. Scientific content, we are having many other platforms and many other CMEs and conferences where we can discuss those scientific content. So please avoid discussing the scientific content. So with all these, I also appreciate the efforts of my team members who are there, Dr. Vidya Thobi and Dr. Vandana Agarwal, who have really worked hard in the background to prepare all the content for the program and for plan all the series of Odyssey of teachers. So let's invite Dr. Vidya Thobi to say a few words and to conduct the program. Then Dr. Vandana Agarwal will be there so that you have all the these drills of 4 important emergencies. And just again, a information to you that all the recordings of all these programs are available on the ICOG website. So you can refer to them anytime, whenever you want to revisit these type of teaching learning methods. So with all these words, I invite Dr. Vidya Madam for proceeding the Odyssey of teachers.
Yeah. Thank you, Dr. Ashok Kumar. And this is a wonderful Odyssey what you have crafted, I must say. And we are doing this since last 1 year, and we have introduced many teaching learning methods on this platform. So today we are going to discuss something about the drills and simulation based trainings. And this always we say that practice makes the person perfect. So repeated practices, repeated drills definitely will teach every student many things. And as per my teachings, I have seen so many students, they definitely like this simulation based or whatever training we are taking. Now, NMC also has made it compulsory for every medical colleges, these skill workshops. So every medical college has got these skill workshops and training modules. So we are today introducing these drills and simulation based learning and in the 4 sessions, and just see how our all professors across the country, they will be teaching about this drills and simulations. I'm just sharing my screen and telling something about the what it makes like. So thank you very much.
Madam,
Yeah.
before you proceed, I would like to introduce you. Yes.
Yes. Yeah.
Yes, so it's an honor to introduce.
You can introduce only as a Vice President FOGSI 2026, and I am a past governing council member of ICOG. That is enough, Vandana. And I must congratulate Vandana's efforts at the back, means back front or forefront both. And I must thank our ICOG team, Dr. Sheila Mane, and whole team, Dr. Pratik Tambe and others, for continuing this program, and it is very useful program for everyone. So whenever we talk of drills and simulation based learning, there are two complementary approaches for enhancing the learning outcomes. One is it focuses on repetitive practices to reinforce knowledge and skills, while simulation based learning provides a controlled environment to apply and refine those real world scenarios. The implementation of simulation training alongside the traditional didactic lectures has shown to reduce errors and improve performance of medical procedures. So we always observe our students how they are performing. So practical performing is very difficult. Whenever we are assessing any MD candidate, we are not asking him to do cesareans or asking him to manage PPH. We are just asking theoretically. But this training in simulation based training definitely helps him in a practical way. By participating in regular drills, healthcare teams can enhance their skills and confidence, can learn to respond quickly and effectively, leading to better management of an emergency when it actually arises. So obstetric emergency drills like PPH, Eclampsia, shoulder dystocia should be practiced in interprofessional groups with residents, nurses, and anesthesiology trainees working together. So it is a always work together culture, and we require each person to act at a proper way. Team-based simulation training has been shown to improve not only technical management of emergencies, but also communication and teamwork, which are very critical for the patient safety in obstetrics. So we have to keep on informing. We should have a good communication skills, and we always embark about the talking to the patient and patient's relatives. One well-known simulation program is Practical Obstetric Multi-Professional Training, that is PROMPT, originally developed in UK, which has demonstrated significant improvements in obstetric outcomes when implemented regularly. So learning through emergency drill, we all know these CPR models and even the emergency labor room models, which are now in every college, they are there available. So what are the key components of a drill? Simulation training drills involve simulated scenarios that mimic real life scenarios. This allows the healthcare professionals to practice their responses in a controlled environment. Second is a team coordination. So effective communication and teamwork are very crucial during an obstetric emergency. Drills help to establish clear roles and responsibilities, ensuring that everyone knows what to do when an emergency arises. So in PPH, always we say that one person becomes a leader and he will tell what to do, what not to do. Practice of technique. The participants practice various manuals involved in the management of a clinical emergency. And fourth is most important is debriefing and feedback as well. So after the drill, team should engage in a debriefing session to discuss what went well and what could be improved. So this is very important, and this reflective practice is vital for continuous learning and improvement. Now, simulation-based learning has emerged as a transformative approach in a medical education, which significantly enhances the healthcare professionals' learning experience and clinical competency. And it represents the man-made illustration of a true world to attain instructional motives through experiential learning. Actually, the main principle behind simulation learning is to utilize simulation aids to mimic real clinical scenarios. So it permits the retrieval of clinical skills through intended practice rather than an apprentice style of learning. One of the most important advantages is absolute freedom for trainees in making and repeating mistakes without harming the patients. So given the restricted working hours and the patient safety consideration, residents have fewer opportunities to practice complex surgeries on patients. So to address this, simulations are used anatomical models, virtual reality, laparoscopic simulators, cadaveric and animal tissue labs for training. So key advantage is ability to repeat the scenarios multiple times until the mastery is achieved. These techniques broaden the students' thinking through creative new approaches in constructive knowledge acquisition and strengthening of skills. So step 1 is conceptualizing the simulation. Step 2 is creating an immersive environment. Step 3 is integrating technology. Step 4, simulation assessment. Step 5 is debriefing, and step 6 is evaluating learning outcomes. So this is a simulation life cycles. So high fidelity simulation use advanced technology to create realistic scenarios, allowing healthcare professionals to practice and refine their skills in highly realistic environment. For example, we all know the virtual reality, laparoscopic simulators, augmented reality systems, high fidelity human body models, etc. Low fidelity simulation uses less advanced technology such as models, mock-up to simulate the scenarios, laparoscopic boxes you have seen, trainings, pelvic models, suture, practice board, etc. Simulation training of a specific surgeries like vaginal hysterectomy, robotic surgery, hysteroscopy simulators, cystoscopy simulators, and obstetric surgery simulations such as forceps delivery, anal sphincter injury repair also exist. So what are the limitations of these? So these learning equipments such as mannequins, software and facilities areas are very, very expensive and need appropriate maintenance. Second is session preparation arrangements can be time consuming and necessitates enough equipment for equal student opportunity. Faculty also need to be suitably trained in operating the gear. So this is very important. The way forward, the future lies in promoting the use of high fidelity simulation for the labs for teaching, obstetric emergency, surgical procedures in a control team-based setting, integrating simulation with other training modalities such as practicing regular emergency drills can create more holistic and comprehensive educational experience. While high-income countries have widely embraced simulation, its adoption in low and middle-income countries have been little slower due to financial and infrastructural constraints. Advancement in technology such as artificial intelligence, we all know everywhere is artificial intelligence, and improved virtual reality applications promise to enhance the efficacy and accessibility of simulation training. The student enthusiasm can be amplified with smaller group size combined with minimal instructional guidance, allowing them to independently manage the task through the active participation and peer discussion. This is very important. Now, we always talk of self-directed learning. So thank you very much. I thank immensely the ICOG team, Dr. Sheila Manen and others, as well as Dr. Ashok Kumar for giving me opportunity. Thank you very much.
So thank you, Dr. Vidya Madam, for enlightening all of us about the basic of simulation and drill teaching learning methods. So it will really help us in understanding what we are going to demonstrate now. And before we proceed further, I have with us our past ICOG chairperson, Dr. Parag Biniwala with us. Dr. Parag, would you like to say a few words?
Dr. Parag, he was there. Yes.
He was there.
So he just messaged. He got a patient in OPD. So he'll come back again.
Okay. We proceed further. We'll wait for him to join and then we proceed further. Dr. Vandana, now you can start with the modules, and we welcome all our faculty there.
Yes, sir. So we'll start with the first session, which is on postpartum hemorrhage. I would like to introduce our esteemed faculty. May I please invite Professor Jyotsna Suri, ma'am? Can we have a CV, please? So Madam is the unit head and in charge of critical care obstetrics at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. She was awarded honorary FRCOG in 2025. She is the vice president of NIGF. She has been the national corresponding editor of Jogi, editor for BMC Pregnancy and Childbirth, and vice president of AOGD 2021 to 22. She has delivered numerous lectures.
Vandana, let's move on with the program,
Yes.
please.
Dr. Rajesh Kumari, madam. Madam is senior consultant at Safdarjung Hospital with over 30 years of clinical experience. Apart from being an FICOG, she has also done her MBA and WHO fellowship from AIMS, a member of the District Quality Assurance Committee and MTP Act Amendment Committee. She was the ex-HOD of CGHS Hospital, Delhi. She has received several awards and is a master trainer of respectful maternity care, which we shall see now. Dr. Professor Manika Agarwal, madam. Madam is the head of the Department of Northeastern Indira Gandhi Regional Institute of Health and Medical Sciences, Shillong. She is a nodal officer in charge of Raj Bhasha Anubhag. She is ex-associate member of RCOG and ex-sub-dean Students Affair. She has published over 80 papers, has been the guide of PG students, has undertaken many IIC-approved extramural projects, and is involved in various community welfare activities. Welcome all. These are the demonstrators who have worked really hard in preparing the drill. Now let's have a look at the drill on PPH.
Shall I start the video?
Yes.
Yes, ma'am.
Good afternoon, everyone. Postpartum hemorrhage continues to be one of the leading causes of maternal mortality worldwide, particularly in the resource-constrained settings. What makes PPH especially challenging is that it can evolve rapidly from a seemingly stable situation to a life-threatening emergency within minutes. And the difference between life and death often lies in early recognition, prompt escalation of treatment, and a well-coordinated team response. Evidence from the maternal safety programs across the entire world have consistently shown that outcomes improve dramatically when the teams are trained to recognize PPH early and respond aggressively with a structured protocol. However, knowledge alone is not sufficient at that time of emergency. So over there, success depends on team preparedness, clarity of roles, communication, and rapid decision making. This is where the simulation-based drills play a very crucial role. Regular PPH drills allow the teams to rehearse the sequence of action from the early diagnosis, activation of the protocols, uterotonic administration, and the blood product mobilization. These drills also help us to identify system gaps, improve the coordination between the obstetricians, the anesthesiologists, nurses, as well as the blood bank services, and most importantly, they help to build the confidence of the team to act decisively. Today, we will demonstrate drill simulation, highlighting the structured and team-based approach to manage this very dreadful obstetric emergency. The objective is not just to showcase technical steps, but to emphasize situational awareness, teamwork, and rapid escalation, which are the pillars of effective PPH management. I hope this demonstration reinforces the message that regular obstetric emergency drills should be an integral part of every maternity unit safety culture. With that, I invite our dynamic facilitator for this session, Dr. Rajesh, who is our senior consultant, and our wonderful residents to begin the PPH drill demonstration. Thank you very much.
Postpartum hemorrhage is one obstetric emergency which is the leading cause of maternal mortality in our country. It can occur in any patient and at any facility. We cannot predict PPH in all the cases, but by timely interventions, following the standardized protocols and working as a team, the death and severe morbidity because of PPH is almost always preventable. We can achieve this zero figure of this preventable maternal mortality because of PPH by practicing these PPH drills in all the facilities at regular intervals. The norms for the drill are: enact every action as if in real emergency, no invasive procedures will be performed, no real patients or the relatives will be there, state aloud every action, state name, dosage and route of drug given, use of communication techniques, and following the respectful maternity care at all the levels.
This drill is being conducted in labor room of VMMC and Safdarjung Hospital, New Delhi. There is a patient, Mrs. Sushila, who is gravida 2, para 1, live 1 with previous normal vaginal delivery. She is a low-risk patient and is in second stage of labor. Dr. Mansi is conducting the delivery.
सुशीला जोर लगाओ, बहुत अच्छे, लगाओ लगाओ लगाओ, जोर लगाओ. मैडम दर्द हो रहा है. I'm doing perineal massage, warm compression to the perineum and not giving episiotomy. लगाओ, जोर लगाओ, लगाओ लगाओ लगाओ. ये लो, अपना बच्चा देखो. Sister, please give injection oxytocin 20 international units IM. Doctor, I always give 10 international units. Has it changed? Oh, sorry. Give 10 international units oxytocin IM to the patient. I've already placed the blood measurement drape under her buttock. Approximately 300 ml of liquor has been drained. I will clamp and cut the cord after 1 minute. Giving injection oxytocin 10 international units IM. I'm delivering the placenta by control cord traction. Using my left hand, I'm giving contour traction over the abdomen, and using my right hand with continuous gentle traction, I'm delivering the placenta with uterine contraction. Placenta and membranes have been delivered, checked, and it is found to be complete. I'm assessing the tone of the uterus. Clots have been evacuated from the vagina, which are collected in the drape. Sister, please check the vitals of the patient. Uterus is contracting and patient is not bleeding. सुशीला अपना जीभ दिखाओ. सुशीला जीभ दिखाओ. ठीक है. Sister, please tell the vitals of the patient. Doctor, her blood pressure is 116 by 70 and her pulse rate is 86 beats per minute. Please assess the patient every 15 minutes for vitals, uterine tone and bleeding. Okay, doctor. Thank you, sister.
Doctor, patient is bleeding. Please come.
अरे इसे तो PPH हो रहा है. प्रतिभा मैम, please come. Sister, please bring PPH tray.
क्या हुआ डॉक्टर मानसी?
Ma'am, she is Sushila, gravida to paravan live and low risk patient who had uneventful delivery 10 minutes back and अब इसको PPH हो रहा है.
How much was the liquor in pouch?
Ma'am, 300 ml.
Oh, she has already lost 800 ml of blood. Sister Ji, Dr. Purushottam, Dr. Nikita, please come. Patient is having PPH.
Yes,
Dr. Nikita, please call Dr. Rajesh also. She just left the labor room after taking downs. Dr. Mansi, you go to the head end of the patient, look at the general condition, her airway breathing saturation. Start oxygen at 6 liters per minute by face mask. Reassure her, take her vitals. Dr. Nikita, you come at the perineal end and help me, but before that, put 2 whiteboard cannula, 18 gauze, grey color, and take samples for blood group for cross match, BTCT, liver function, kidney function, quad profile.
Okay, ma'am.
Sister G, transfuse 1 liter of RL over 15 minutes and give injection oxytocin 20 international units at 40 drops per minute. Also give injection tranexamic acid 1 gram over 10 minutes. I am massaging the uterus. Dr. Purushottam, you please be the observer and note down all the important steps. Dr. Mansi, please tell the vitals of patient.
Ma'am, patient is drowsy. Sushila G दिखाओ अपनी. She is pale. Ma'am, her saturation is 93% at room air. Her BP is 90 by 60 millimeter mercury and her pulse rate is 110 beats per minute.
Sister G, continue giving oxygen and the fluids. Please keep Foley's catheter and keep the tamponade ready. I am continuing the massage.
सुशीला घबराओ नहीं, ठीक है? तुम्हें डिलीवरी के बाद फिर ज्यादा ब्लीडिंग हो गई है तो हम तुम्हारा ध्यान रख रहे हैं, ठीक है? घबराओ मत.
Sister G, please keep the patient calm.
सांस लो इससे.
I
घबराओ.
am continuing the massage and removing clots from the vagina. Foley's catheterization has been done. Dr. Mansi, please inform the relatives and take proper informed consent. Inform first on call and also inform OT.
Yes, ma'am.
Along with inform blood bank and arrange the blood products.
Okay, ma'am. Hello, OT sister. Please keep the OT table ready for a patient named Sushila who is having PPH in LR. She might need the OT. Hello, ma'am. Ma'am, we had informed you a patient Sushila who was having PPH. She is still continuing to bleed. We think that she might need the OT, ma'am. Hello, blood bank. We are sending requisition for a patient who is B positive and having PPH. Please arrange the adequate blood products. Do we have the blood products? Please let me know. Thank you. आप सुशीला के पति सुनील है?
जी मैम.
सुशीला की डिलीवरी हो गई है. उसने एक स्वस्थ बच्चे को जन्म दिया है, लेकिन डिलीवरी के थोड़ी देर बाद उसे बहुत ज्यादा ब्लीडिंग हो गई है. लगभग 800 ml का ब्लड जा चुका है उसके शरीर से. फिलहाल के लिए हम मरीज का ट्रीटमेंट कर रहे हैं, पर मरीज को हो सकता है कि हमें ओटी टेबल भी ले जाना पड़ सकता है, जहां हम पहले तो उसका इलाज करने की कोशिश करेंगे, पर अगर ब्लीडिंग नहीं रुकी तो हो सकती है कि उसकी बच्चेदानी भी निकालनी पड़ सकती है. फिलहाल के लिए हम ब्लड बैंक से उसके लिए खून की व्यवस्था कर रहे हैं, पर आप भी अपने साइड से ब्लड डोनर्स मंगा लीजिए. आपको मेरी बातें समझ आ रही है?
जी मैम. मैम अभी तो वो ठीक थी, अभी क्या हो गया मैम?
मैंने समझाया ना आपको, उसको ब्लीडिंग बहुत ज्यादा हो गई है, तो हम उसको इलाज कर रहे हैं. घबराओ मत, ठीक है? हम अपनी साइड से पूरी कोशिश कर रहे हैं. आपको मेरी सारी बातें समझ आ गई है?
जी मैम, समझ में आ गई. मैम वो ठीक तो हो जाएगी ना मैम?
हम पूरी कोशिश कर रहे हैं, ठीक है?
जी मैम.
Dr. Nikita, give me cervico-vaginal exploration tray and keep the balloon tamponade tray ready.
Yes, ma'am.
Dr. Mansi, was the placenta and membranes removed completely?
Yes, ma'am. I checked for the completeness of the placenta.
Okay. Sister G, give injection methyl ergometrin 0.2 milligram IM stab to the patient.
Doctor, injection methyl ergometrin is not available.
Okay, Sister G, then give tab misoprostol 800 micrograms sublingual to the patient. Exploration has been done. There are no tears. Dr. Mansi, please tell the vitals of the patient.
Ma'am, her pulse rate is 108 beats per minute and her BP is 100 by 60 millimeter mercury. But still, she's still pale.
Patient is still bleeding. I'm removing the clots. सुशीला, तुम्हें कोई दमे की दिक्कत तो नहीं है?
मुझे नहीं पता मैडम, अभी तक तो कभी नहीं हुआ था मैडम. छोड़ दो मुझे.
Patient is still trickling. I am inserting the balloon tamponade. Dr. Nikita, please give external aortic compression.
Yes, ma'am. I'm placing my fist above and slightly left to the umbilicus and pressing down towards the spine and hence putting the aortic compression. Now I am feeling for the femoral pulsation. I cannot feel the femoral pulse and hence the external aortic compression is effective, ma'am.
Bleeding is now controlled after instilling 350 ml of normal saline in the balloon tamponade. Dr. Nikita, please mark the fundal height.
Yes, ma'am.
Blood has also come. Dr. Nikita, please check and start the blood transfusion. We have observed patient for 10 minutes. There is no active bleeding. PPH has been managed. Total blood loss is 1300 ml. Dr. Mansi, please tell the vitals of patient.
Ma'am, currently the patient pulse rate is 98 beats per minute and her BP is 110 by 70 millimeters mercury.
Thank you. Patient has been managed for now. Let's just all come and do the documentation.
Yes, ma'am.
Dr. Pratibha, how was your experience about the whole drill?
It was a great experience, ma'am. We all knew our parts.
Yes, you all knew your parts, so it went very smooth and the patient was being managed very nicely. So you see, when you work like a pin girl and you be at the head end, perineal end and the arms end with the defined role, everything goes smooth and the patient gets managed well. Like Dr. Mansi went at the head end and the team leader Dr. Pratibha gave clear instructions what all to be done by the head end person and what all to be done by the arms end person nursing officer, and Dr. Nikita was helping her in the perineal end and everything was done smoothly. And Dr. Priyanka, as nursing officer, how was your experience? Were you given proper instructions by the team leader?
I was given very clear instructions regarding the drug and the route of administration by Dr. Pratibha.
Dr. Nikita, while you all tried to incorporate all the FIGO 2025 guidelines on PPH, but could you please enumerate the guidelines of the 2025 FIGO about the prevention of PPH?
Yes, ma'am. According to the latest FIGO 2025 guidelines, the prevention of postpartum hemorrhage includes supplementation of iron folic acid in the antenatal period and even after delivery for next 100 days. It also includes good perineal support during delivery. Routine episiotomy is not recommended. It should be given only when indicated. Also about uterotonics, oxytocin is the drug of choice when in conditions where cold chain is difficult to be maintained. Apart from oxytocin, tablet misoprostol 400 to 600 micrograms can be given orally, or heat stable carbitocin 100 micrograms IM or IV can be given. The drugs that are not recommended in the prevention of postpartum hemorrhage includes ergometrin, methyl ergometrin, fixed dose combination of ergometrin and oxytocin, injection tranexamic acid, and also it includes
injectable prostaglandins. And anything in the prevention about the controlled cord traction and uterine massage, Dr. Nikita?
Yes, ma'am. In conditions or in situations where a skilled birth attendant is present, controlled cord traction is to be done. Delayed cord clamping is done. Routine uterine massage is not recommended for the prevention of postpartum hemorrhage. It is done only for the control of postpartum hemorrhage.
Dr. Pratibha, although you had a very smart junior resident, Dr. Mansi, who could diagnose PPH timely and call you for the help, but could you throw some light on the diagnosis of PPH according to the FIGO guidelines 2025?
Yes, ma'am. Any blood loss of more than equal to 300 ml with abnormal hemodynamic signs of heart rate more than 100, systolic blood pressure less than 100, diastolic blood pressure less than 60, shock index more than 1 with flabby uterus, atonic uterus, or any blood loss of more than equal to 500 ml in a vaginal delivery is PPH.
Yeah, irrespective of any hemodynamic signs.
Yes,
yes. Dr. Nikita, in your patient, what all you did as the first response treatment and then when it became refractory PPH?
In the first response treatment, we followed the motive bundle according to the FIGO guidelines, where motive stands for M is for massaging the uterus, O is for oxytocins, T is for tranexamic acid, I stands for intravenous fluids, V is for vaginal and genital tract exploration, and E stands for escalate of care. In the refractory PPH, In our drill, we followed the external aortic compression and also followed by the uterine balloon tamponade.
Dr. Mamta, as a patient, how was your experience? Were you feeling scared on the way they were treating you?
No, ma'am, I wasn't scared at all, ma'am. In fact, the team members were giving me respectful maternity care at all times, ma'am, and I was being counseled regularly for whatever was happening to me during the drill.
Dr. Purushottam, you played the double role in the drill. First, as the observer, please tell us your experience. Were you able to note down the events in the checklist properly?
Yes, ma'am. In the drill, I was able to note down all the events that had taken place in drill.
Yeah, and as the stressed husband, were you counseled?
Yes, ma'am. I was counseled properly that I am not anxious that my wife is in dangerous, but I was happy that doctors are very talented and do very respectful work to save my wife.
And Dr. Mansi, here in the tertiary care setup, you could manage this patient well. But suppose you were at a primary health center with the same kind of PPH patient. What differently you could have done at that place?
Ma'am, after following all the steps in active management of third stage of labor, by doing the timely diagnosis of PPH, after doing Foley's catheterization and following all the measures of first motive, I could have even explored the genital tract for any tear, and after inserting the pack, and then I could have referred the patient to the tertiary care center in NASG government.
Yes, the timely referral is the key to save the life of the mother when you are working at a smaller setup. Dr. Pratibha, any other modalities which could have been used in the patient of PPH which you couldn't show in the drill?
Yes, ma'am. There are other modalities. One of them is Paniker's suction cannula, which could have been used. Also, if interventional radiology is available and bleeding is controlled, uterine artery embolization is also an option.
So it is always better to save the patient. Think of saving the patient first rather than saving the uterus. So hysterectomy should also not be too delayed. Dr. Priyanka, what all communication techniques did you use in the drill?
Yes, ma'am. So different methods of communication was used. First was calling out for help, which Dr. Mansi and Dr. Pratibha called out for help when they saw that the patient was having PPH. Checking back, I checked back all the drugs and the route of administration after instructions were given to me regarding the same. S-bar was done by Dr. Mansi after she debriefed Dr. Pratibha about the condition of the patient. Dr. Pratibha was thinking out loud at all times and giving all of us clear instructions regarding our roles and the drugs to be administered. And I respectfully challenged Dr. Mansi by the 2 challenge rule when she had recommended a different route, a different dose of oxytocin.
Yes. So carry home message is PPH is best managed at the place of delivery. The first golden hour is the golden opportunity. Management of PPH is a teamwork. The PPH drills are to be carried out at all the laboring facilities at regular intervals. Stop PPH, save mothers.
Yes. So I'm sure everybody will say it was wonderful. May I please invite our experts? Professor Manika Madam, Josna Madam, Rajesh Madam.
Should I start?
Yes, ma'am.
Good afternoon, everyone. At the outset, I'd like to thank Dr. Ashok Kumar, Dr. Vanna Agarwal, and Team ICOG for giving me an opportunity as an expert to give my inputs. An excellent demonstration of simulation-based learning of how to manage PPH was carried out by Dr. Rajesh and her team. Let me just share with the audience that I have recently completed my course, an advanced course on medical education. And I'm also a member of Regional Center for NMC at Negrins. I'm a resource person for faculty development programs, where we acquaint the faculty with different learning principles, domains of learning, and teaching learning methodologies. As my task today is to give inputs on this teaching learning methodology, which is simulation-based management of this very crucial life-threatening obstetric emergency, that is PPH drill. As we know, this will help the learner develop all the three domains of learning, that is knowledge, skill, and attitude. When we come to skill, there are two parts to it, communication skills and what needs to be done. When we come to communication skills, there was debriefing done on three parts: how to counsel the patient, how to counsel the attendants, and how to counsel the team, so that every member of the team has a clarity on their role and follow the structured protocol. As far as the technicalities of management of PPH was concerned, they were also demonstrated well, whether it be the massage, giving the uterotonics, calling for help. So as has been expressed by my earlier speaker, Dr. Vidya also, that these repetitive practices helps the learner to retain it better and reproduce it as and when required in these kinds of infrequent but life-threatening crucial emergencies. At the end, Dr. Rajesh did a debriefing of all the participants, asking them to reflect and see what was done well, what are the existing guidelines, and what better could have been done. As a whole, I think so we all agree it is an excellent teaching learning methodologies which will help our both UGs and PGs to be able to reproduce the techniques for the management of PPH and thus contribute in saving lives. Thank you everyone for your patient hearing.
Jyotsna madam, would you like to add anything?
Dr. Jyotsna, your expert comments.
Maybe the video is stuck.
Dr. Parag Biniwale has joined, so if he wants to give some comments.
Yes, good afternoon, sir.
Good afternoon. No, I'm just here to congratulate the ICOG team, Dr. Sheila Mane, Dr. Pratik, and of course, Dr. Sadhana Gupta. And I'm really happy that this program, which was conceptualized in the last year, luckily I was the chairman of ICOG at that time. So I want to thank and compliment Dr. Ashok Kumar, Dr. Vidya Thobi, and our youngest member of this team, Vandana. Thank you for taking this program ahead. And when I logged in, seeing a magic figure of 200 attendees was really hard.
Yes.
So hats off to all of you for your persistent work and keep doing excellent work. And of course, ICOG is always there for teaching and learning. So please carry on with the activities. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you.
Jyotsna madam, would you like to add anything? You're muted.
You have to unmute Jyotsna.
Yeah, thank you, Parag. Thank you, Parag, for joining.
Yeah, so I don't really have to add because we just have to say that we enjoyed doing this drill, and Dr. Monica has given us so many insights into this further about our the drill and about these teaching methodologies which was stressed upon by Dr. Ashok and Dr. Vidya Thobi. So this kind of experience for our PGs was totally, it was something they all enjoyed, our senior resident and our PGs. It reinforced whatever, small gaps in the, when this actual happens, this kind of emergency, there are still small gaps, even after knowing everything. So these small gaps were covered during the drill. While they were doing, they themselves were, giving their feedback and covering it up. So that was what I really found really good about, this kind of teaching. And I wish that such kind of further programs are, more and more available for our PGs, and they are encouraged to take part. And Dr. Rajesh worked really hard. I would like her to give her experience also.
Thank you so much, everyone. Actually, in Safdarjung Hospital, we have a regular practice of conducting these PPH drills on a monthly basis. We have the skill refresher training every month
for the people who are doing the labor room, residents who are doing the labor room in that coming month. So it is a usual practice, but still, every time some error or the other, it occurs. And then in the debrief, we try to cover that. And all the residents, they realize where and when they are going wrong. And because the prompt management is very important in PPS. So these methods are really of very much of use. Like in Safdarjung Hospital, despite having, almost more than 200 maternal mortalities in 1 year, hardly we have deaths due to PPH, which is otherwise the leading cause of maternal mortality. Debarring those who are coming from outside after having the PPH, those are different cases. But per se, we have other causes. So these drills play very important role when it comes to these kinds of obstetric emergencies management. Thank you.
Thank you, Madam. Vidya, Madam.
I think we will move to the next session.
Thank you, Manika, Madam. Yes.
Welcome. It was my pleasure to be an expert and give opinion.
Thank you.
Yes. Thank you very much, ma'am. So let us move to our session 2. And I welcome our next experts. We all know them. Dr. Lata Chatur Edula, who is a professor and my dear friend from JIPMER, Pondicherry. Faculty of Medical Education. She is a president of OBG Society, Pondicherry. Executive MBA. She has got many awards and 2 ICMR funded projects, COVID in pregnancy and others. She has got many vast areas of interest, means diverse. One is high risk obstetrics and preventive oncology and infertility. She has got a passion for normal deliveries and she has vast experience also. So welcome Dr. Lata. She is in operation theatre though. Second is Dr. Kirti Priya. She is also from JIPMER, Pondicherry. She is, I think, working as an assistant professor in JIPMER, Pondicherry. Her interests are cardio obstetrics and obstetric critical care. So she has been certified as a fundamental critical care support in obstetrics from SCCM and advanced university certificate course as well in fetal medicine. I also welcome Dr. Geeta Duppa. She is also my dear friend and she is from professor and head of the department from KBG Medical College, Surya. She is interested in fertility and high risk obstetrics. She has held many posts in IMA. I know her very well and she is very vibrant personality. She has got awards, many awards to her credit. So over to the team, this team to demonstrate and have skills of shoulder dystocia. So Vandana, can you share?
Yes, Lata Madam would like to share.
I'll try to share.
You will share.
Thank you so much. I would first of all thank ICOG for giving us this opportunity to do this, and especially Dr. Ashok. We've been good friends, though he's much senior to me, and Vandana, and of course Dr. Vidya Tobi. Thank you all for this opportunity. But I would say that the team from Safdarjung has done an excellent job. I don't know whether we'll match them. But yes, again,
2 emergencies are different. So,
so before we move on, I'll just share my slides. Yeah. Is it seen? I'll put it in.
Yes, ma'am.
Yeah. So I bring greetings from Pondicherry. For many of you who don't know Pondicherry, it's just little 150 kilometers away from Chennai. So we have been given the job of demonstrating shoulder dystocia. So these are my team members. We have Dr. Navina, who's the junior resident, Dr. Tejas, who's the senior resident, Dr. Harita Mohan, again, was the senior resident, Dr. Kirti Priya was the assistant professor, and myself. So before going to the video, I just want to say when to anticipate shoulder dystocia. How do we manage once we diagnose and what are the complications we anticipate because of shoulder dystocia? So when to diagnose shoulder dystocia is after head delivery, if there is difficulty in delivery of the shoulder. So usually if within 60 seconds, if the shoulder doesn't deliver, then we have to anticipate shoulder dystocia, which occurs in 1% of all deliveries. And what we see is a turtle sign, that is retraction of the baby against the maternal pelvis. So what are the risk factors? The risk factors are, all of us know what we call it as dope, a big baby. And the reason for dope is diabetes, obesity, big baby, and excessive weight gain and past days. So these are all the reasons why shoulder dystocia will occur and why a big baby occurs. Past days, especially post-term pregnancy, all these lead on to the big baby. And of course, if there is history of prior shoulder dystocia. Now, moving on to the management, first thing, as it was told in PPH, we also have to call for help. We make sure that patient always gets adequate analgesia when she's in labor. A liberal episiotomy, though we say no episiotomy, for this liberal episiotomy is a must. And we need to deliver the baby within 4 to 5 minutes of the delivery of the head. So I'll just show the video.
And the volume is not there. The audio.
1 second. 1 second. Just let me. Volume is not there?
No, ma'am. Maybe.
Ma'am, you have to click on the sound, ma'am.
1 second.
Share sound.
1 second. Share sound.
We'll play the video, ma'am.
Yeah, video you can play. Yeah, sure.
Shreya, please play the video.
Yes, ma'am.
1 second. Let me stop share.
Yes. Only the video, Shreya.
I've sent it separately. Yeah.
Yes.
Amma, nalla முக்குங்க 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 நல்லா
Can you hear now?
முக்குங்க முக்குங்க. Someone please call Dr. Tejas sir. Shoulder is not coming out. I'm not able to deliver the shoulder.
Okay, what happened? You are unable to deliver.
Yes, sir.
Amma mukkadinge ma ippo sariya na sollatana mukkadinge. Have you given adequate episiotomy?
Yes, sir, I have given.
Yeah, hyperflex the thighs against the abdomen. Yeah, flex it. Yeah, mukkadinge ma, this will help in making the sacrum go down and the subpubic symphysis to come up, which will increase the diameter of the outlet. Okay, you try now. Not coming?
No, sir.
Okay, so I'll give a suprapubic pressure from left to the right side, sustained pressure. This will disimpact the anterior shoulder to go into the oblique diameter of the pelvis. Now you try. Yeah.
Yes, sir.
Yes, deliver. Yeah. Is the baby coming?
No, sir.
Okay, with macrobuds it is not coming, so I'll try to deliver it with posterior arm delivery. Okay, so I'll make space and I'll go inside and I'll try to find the posterior shoulder. So I have to trace it along its arm, and in the antecubital fossa I have to compress it and try to catch hold of the forearm of the baby and run it across the chest gently and bring it out. So this will disimpact the anterior shoulder and help in delivery of the baby. You have to go along the sacral curve, try to find out the antecubital fossa of the posterior arm. So once catch hold of the baby's arm and sweep it along the chest of the baby gently and bring it out. So this will disimpact the anterior shoulder to come below the symphysis pubis and we can deliver the baby. I am unable to deliver the baby as the posterior shoulder is not accessible to me. Please call Dr. Harita for internal maneuvers.
Next we will try the Rubens maneuver. In the Rubens maneuver we will go along the back of the baby, access the posterior aspect of the anterior shoulder and give pressure towards the chest of the baby, which will bring the diameter of the shoulder into the larger oblique diameter, and that will facilitate the delivery of the baby. In Rubens maneuver, we will apply pressure over the back of the baby from the posterior aspect of the anterior shoulder, and we'll give pressure towards the baby's chest which will disimpact the anterior shoulder from the pubic symphysis, and then the baby's shoulders will come to lie in the oblique diameter of the maternal pelvis, which is a larger diameter, which will facilitate in the delivery of the baby. I'm not able to do the Rubens maneuver. Can somebody please call Dr. Kirti Priya?
So the Rubens has failed. Now we'll try the Wood's corkscrew maneuver. So I will go posteriorly, try to locate the posterior shoulder, keep 2 fingers over the anterior aspect and try to rotate the posterior shoulder by 180 degree. At the same time, I will try to locate the anterior shoulder, 2 fingers behind the anterior shoulder and try to help in the rotation of the baby. So we'll try to rotate the baby by 180 degree. By this maneuver, you can see the impacted anterior shoulder has gone posteriorly. The posterior shoulder has come anteriorly, which will facilitate the delivery of the baby. So now the Rubens maneuver has failed. We'll see how to do the Wood's corkscrew maneuver. So here you can see the anterior shoulder is impacted under the pubic symphysis. So I'll go posteriorly, trace the posterior shoulder, keep 2 fingers over the posterior shoulder and give a push to rotate it anteriorly. At the same time, try to locate the posterior aspect of anterior shoulder and try to rotate the anterior shoulder. So by this, we give a corkscrew movement to the baby and rotate the baby by 180 degree. So now you can see the posterior shoulder is anterior and the anterior shoulder got disimpacted from the pubic symphysis, and this will help in the delivery of the baby.
So when all these maneuvers have failed in lithotomy position, what we can do is Gaskin's maneuver, where the patient is put on all fours. What will happen here is it will facilitate the descent of the baby with gravity, so that the anterior shoulder which was impacted can be easily delivered. One of the procedures which was done historically is cledotomy, where we deliberately fracture the clavicle of the baby, which will help in decreasing the bisacromial diameter so as to facilitate the delivery of the shoulders. Another procedure which has been historically tried is symphysotomy, where they give local anesthesia and cut the anterior pubic ligament. Because of this, what happens is there will be widening of the sutures between the pubic symphysis. Because of this widening, it will help facilitate the delivery of the baby. In case all the maneuvers which have been discussed till now have failed, we have no other option. As a last resort, push back the head into the maternal pelvis and do cesarean section, which most often than not is not done. It is an obsolete procedure because there are more complications of pushing back the head and trying to deliver the baby by cesarean rather than trying not all these maneuvers.
Can you stop the video?
Amma, nalla mukkunga.
Yeah.
Mukkunga.
Shreya, madam, would you like to show the PPT or we will share it?
Yeah, you can share the last. There are only 2 more slides. So after looking at, I'll be talking, you can show the...
Yeah, yes, ma'am.
I think close the video. Okay.
I don't know whether there is a problem
Ma'am,
with
the
your...
complications, ma'am, this slide.
No, that's fine. What I'm saying is there is some disturbance in the PowerPoint. There are some gray areas coming up on the slides. I'm not sure whether it's for us or it's for you.
It's
Doesn't
all
matter.
clear, ma'am. It's all okay.
Okay, fine. Something is happening. Okay. So when we talk about shoulder dystocia, these are the 2 maneuvers. Most of the time with McRoberts maneuver itself will be able to deliver. One more thing I would like to tell here is, whenever you're anticipating a big baby and a shoulder dystocia, it depends on size of the patient also. For a smaller built patient, even a small baby, even 3 kg, they can have shoulder dystocia. Usually we anticipate it beyond 3.5 kg. So in those cases, there is no harm in, flexing the legs over the abdomen, and because this will give some space in the pelvis so as to facilitate the delivery of the baby. So, we have hardly done corkscrew maneuvers, or most of the times with macrobursts they deliver, or maybe with delivery of the posterior shoulder. We have never had to do cleidotomy, never had to do, of course, symphysiotomy and all is totally unheard of nowadays. After this, of course, nothing goes without complications. Maternal complications, we know postpartum hemorrhage mainly because of over distended uterus, because of big baby, and they have etonicity. And with all these maneuvers, we may have vaginal tears and lacerations which have to be managed. So always after delivery, don't be in a hurry. Look for, you've all heard about how to manage PPH, and that is very important. You have to anticipate which patient will have PPH. Another thing we can anticipate is having Erb's palsy in baby, especially when we are giving pressure over the shoulder. We'll be compressing so they do develop Erb's. I won't say palsy, it's paralysis most of the times. We don't have palsy, usually it recovers. Fracture of the clavicle has occurred, but this goes unnoticed because most of the times babies are not that symptomatic. We can have fracture of long bones, especially the humerus, while delivering the babies. Babies can go in for asphyxia if the time gap between the delivery of the head and the shoulder goes on more beyond 4 minutes or 5 minutes. And of course, they can have severe acidosis. So these are the complications which you can anticipate, and we should look for during the delivery of when there is shoulder dystocia. Can you go for the next slide? I think with that. So again, I thank everyone who have given us this opportunity for demonstrating shoulder dystocia. And I also thank our residents and the consultants who have been part of this. Most important, I would like to thank our studio people who have actually helped us shoot the entire this thing. Thank you all once again.
Thank you, madam. Vidya ma'am.
Dr. Geeta is there, no?
Yes, ma'am. Good afternoon, everyone. So at the outset, I thank all the esteemed office bearers of ICOG for giving me an opportunity to be an expert here. Dr. Bhaskar Pal sir, Sheila Mane ma'am, Vidya Thobi ma'am, Ashok Kumar sir, Vandana, and everyone. So excellent shoulder dystocia drill by the team JIPMER. It was really very good. So as we all know, shoulder dystocia is the impaction of the shoulders, fetal shoulders above the pelvic brim. And though since PG days we are knowing the risk factors, DOPE, as ma'am said, the DOP, that is diabetes, obesity, postdatism, excessive weight gain in pregnancy, or it may be history of shoulder dystocia in the past pregnancy. Even all these things are there. This shoulder dystocia is really unpredictable. We really can't predict it because 2/3 of the cases which I have faced, they really did not have risk factors where I anticipated. Okay, so many times it comes as some surprise to us in the labor room. So any one of us who is doing the delivery, so they should be knowing something about this shoulder dystocia. And for this drill was really excellent because it may be a junior resident, senior resident, or any assistant professor, they can face this situation anytime. So everyone must be well versed with what has to be done when we encounter with such a situation. So excellently, the drill was performed where the junior resident was trying to deliver the baby, but she found after the gentle traction, what routine force she uses when the baby is not delivered, immediately she gave call to her senior. Yes, definitely call for help is very important. We call our seniors, we give call to the neonatologist or pediatrician and also the anesthetist if required. Then they have tried the external maneuvers. Yes, the MacRoberts maneuver, which as ma'am said, prophylactically where you are anticipating or maybe we may encounter shoulder dystocia, you can prophylactically use this MacRoberts maneuver, which will increase the anterior-posterior diameter of the outlet and help us preventing the shoulder dystocia. Yes, after that, and all the maneuvers, we at least use only 30 seconds. If you are not able to do this maneuver, go to the next maneuver. Don't waste time. As ma'am said, in 3 to 4 minutes at any cost, we have to deliver the baby. Otherwise, there is no point in delivering the asphyxiated baby. So every maneuver has to be done meticulously and with the time span. We can keep one person or one resident to keep the time, and he can tell, yes, 30 seconds, go for the next. If we are having that thing in the drills also, that will help us when the real situation arises, because all will be in a state of panic. That we must understand that we did not panic. Once we know what has to be done, we will really not panic there. The next is, yes, giving the suprapubic pressure or Rubin's 1 maneuver, what we said. So as we do the CPR, like that with the palm, we can do this suprapubic pressure, and we can give sustained pressure, or we can also give thrust. Okay, that's what we call the rocking of the symphysis pubis. So with that, many times, as ma'am said, most of the time in 60% of the cases with these 2 maneuvers only, we are able to deliver the baby. But yes, if these maneuvers don't work, a senior steps in, and there we may have to call an anesthetist, because if any analgesia, anesthesia is required, and then you have to give a liberal episiotomy, and then all the internal maneuvers start. That is delivering of the posterior arm, or it may be the Rubin's 2 maneuver, Wood's corkscrew maneuver. So all these maneuvers, and then lastly the Gaskin's maneuver. So with all these things, most of the times the baby will be delivered. But if not, as ma'am said, Zavalini's technique or symphysiotomy, clidotomy, all these things we have really not seen. But for the postgraduate, for theoretical purposes, they may do. But really, if it doesn't work, sometimes we may have to shift the patient to the OT, give an incision on the uterus, and rotate the shoulder and deliver it vaginally. But that time we can't expect a live baby. But to reduce the trauma for the mother, prevent the tears to the uterus, all those things we can try as last resorts. So here, after doing all these, very important for us, one is our team should be ready. For that, we should be regularly performing these drills, because we are used to it. If this doesn't work, this doesn't work, this. In the meantime, our team should be solacing the mother. We should tell her, don't worry, and we should pacify her. One person should go and tell the relatives that this is happening. And one more team must be ready for documentation, because many times we'll end up in medico-legal problems when we lose the baby, when we give permanent nerve injuries or some neuropraxias or maternal traumas. We may face some medico-legal issues. For that, documentation also should be ready. For that also, our one team should be there to document when it happened, what we did, who came, who attended the call, what was done. So everything should be documented. So if these drills, we do it at regular basis in our college or in any institute, teaching institute, definitely if we come across such surprises, we all will be prepared for it. And definitely we should be ready to tackle the complications like PPH. After all this, sometimes we may face traumatic PPH. So all these things also we must be ready. Only 2-3 things what we must understand is, more than 60 seconds, the shoulder is, after the delivery of the head, shoulder is not delivering. Ask the mother not to bear down. Don't give undue pressure on the head. And thirdly is, don't give fundal pressure. Many times what happens, the residents will be in the thing that they will give fundal pressure. We are making the situation worse. We will make the shoulder impacted more there. So don't give fundal pressure. It will cause more problems. Also, sometimes it may lead to rupture of the uterus. So if these things, if we take care, definitely, even if these situations come to us with surprises, we will all be able to tackle these problems, because nowadays we know so many cases of GDM will be there, obesity are there. So definitely all should be well versed with all the different drills. And once again, I congratulate team Jitmar for the excellent shoulder dystocia drill. Thank you.
Ma'am, before we just move on, I just want my assistant professor, Dr. Kirti Priya, to say a few words.
Yeah.
About
Dr.
her experience in doing this.
Yeah.
I'd like to thank
Most of the time it is a surprise only, no?
Yes, it's a surprise.
It is a surprise.
Yeah.
The
Yes,
best thing
Dr.
is that
Kirti?
sometimes you should not take the surprise most of the times with large babies, or if it is a big size or deflexate. In that, if you screen it out, then there are less.
Dr. Kirti?
Yes, ma'am. I would like to thank the team for giving us this opportunity, and it was a great experience working with my residents and also
personally, I have done only with posterior posterior arm delivery when I was a resident. So learning other techniques and doing it was also a learning experience for me. So thank you.
Yes.
Thank you. We have also learned lot of our mistakes while making this video. So I thought next time we have to improve. I was just telling. I mean, looking at
No,
PPH,
it was
lot of
good
things
and
we
it was
not
excellent only. As a drill, we always talk of that simulation training, the team coordination, repeated practice of the technique, and debriefing and feedback. So in this, we learned all these four, and we learn from our own mistakes. So
Yes.
if you do repeatedly, definitely we find out how best we can do it. Many times in our lifetime we may not face, but sometimes if you face, then what to do or not, what not to do also. That
And
is
most of the
I
times
think,
it is senior
Lata,
residents who
I missed it. You must have spoken about documentation, right?
yes, Dr. Geeta mentioned it about the documentation and medical legal aspects.
Yeah,
So
because there
that
is a form actually for that, no? That we have to.
shoulder dystocia, there is a form also, what to fill at what time and when you have done which maneuver and all. So that is very important. Thank you very much. The whole team was excellent. Thank you very much, Chikma, Dr. Geeta, Dr. Kirti, and whole other team. Thank you, Rajashri, for your comments, and Dr. Sheila also.
Thank you, ma'am.
Let's move for the next session.
On eclampsia.
Very good. I think very good attendance, Vandana, 217.
Yeah.
Yes. We have also circulated lots of
personal calls.
All students.
It's all because of the experts, ma'am, and the students have worked so hard the past 2 weeks.
Teamwork.
Yes.
So our third session, no?
Yes, ma'am.
You would like to introduce
Yes, madam.
Runa ma'am?
Yes, so it's an honor to invite our expert, Dr. Professor Runa Ball, madam. She is the head of the Department of Obstetrics and Gynecology at Neel Ratan Sarkar Medical College, Kolkata. She has a teaching experience of 25 years, over 35 publications in national and international journals. She has been the speaker in various conferences and is a renowned examiner. She is actively associated with numerous health programs at the Government of West Bengal, UNICEF, and WHO. She has a special interest in adolescent health, high-risk pregnancy, and oncology. Welcome, madam. Dr. Mini Sen Gupta, next slide, please, is Associate Professor at Neel Ratan Sarkar Medical College, who has worked along with Professor Runa Ball, madam, and Dr. Ramesh Ranjan Haldar, sir, who is working as, the next slide, please, as he is working as an assistant professor at NRS Medical College, Kolkata. Our expert faculty, Dr. Professor Jitesh Shah, sir. He is working at the Surat Municipal Institute of Medical Education and Research. He has various publications in national and international journals. He holds various posts in the Surat OBGY Society and is a renowned national level faculty. Welcome, sir. Can we, yes, so these are the demonstrators, and can we please have the drill now on eclampsia? Shreya?
Hello. Welcome to NRS Medical College, Department of Obstetrics and Gynecology. So today we'll perform a drill on eclampsia, the management of eclampsia. So me, Dr. Professor Runa Ball, is a HOD of this department. Will be assisted by Dr. Mini Sengupta, Associate Professor of Obstetrics and Gynecology Department, Dr. Ramesh Ranjan Haldar, Assistant Professor of this department, Dr. Anubhati Nag, RMO cum Clinical Tutor of our department, Dr. Shanghamitra Bose, SR of this department, and our beloved junior doctors, Dr. Monisha, Dr. Madhurima, Dr. Annesha, Dr. Shayesta, Dr. Priya, and our nursing staffs. They will assist us today in this drill. Thank you.
I see my patient.
Okay. Please sleep.
She is actually complaining. Her name is Bornali.
Okay, what is her age? Kindly
29.
Okay, is she pregnant for the first time?
Yes.
Okay.
Suddenly her legs have swollen up so much and she's complaining pain over here. And she was about to fall also once.
Okay, is she taking any medication?
Yes, she recently had high pressure, so she was given one high pressure tablet.
Were you taking medications previously? Why didn't you take your medication for the last 1 week? Dr. Madhurima, please come and check her BP. What is the gestational week? Can you please tell me?
Week, I think her date is actually on
When was the
14th
last
of
treatment?
March.
Okay.
6th of June, na? 7th of June.
Okay, so it will be near about 37 weeks.
Yeah.
Okay. Pulses. Is she having leg swelling?
Yes, like since yesterday only.
When did this start, ma'am?
Since
2 weeks you're having swelling. Are you having any blurring of vision?
I have.
You're having headache?
From today's morning.
From today morning you're having the symptoms. Okay. Did you take your medications today?
No.
Why? What is her BP?
Her BP is 180 by 100.
180 by 100. What were you doing?
Did you get a urine dipstick?
Yes, please.
Urine dipstick.
Please, someone help.
See, something has happened to her.
Please come. Dr. Anubhati ma'am, please come.
Please having
Please get
conversion.
the eclampsia tray, someone.
Please having conversion. Please come.
Please, we need the team.
Please, Anubhati ma'am. Dr. Anubhati ma'am. Please.
Come.
Monisha, Dr. Monisha, please come and sit. She is having conversion.
It's an obstetric emergency. We need to act quickly over here. Please
Sit.
secure her here. Please secure her here.
Sister, please come. Sister, please come.
Please provide a mask.
She needs mouth clearance, nose clearance, mouth gap, please.
Give oxygen.
Dr. Monisha.
Yes, sir.
Her BP is so high, 180 by 120.
Yes,
Give her injection labetalol, 20 milligram, IV slowly. And after that, you prepare Maxalf injection. 4 gram IV deben, IV to be given, and 10 milligram, 5 gram each buttock. Okay.
Dr. Shangomitra, please inform the on-call anesthetist. We need their help.
This is the IV loading dose of Maxor.
So can I start IV loading dose?
Yes.
Yeah, I'm informing the anesthesia team for immediately regarding a patient of eclampsia in our eclampsia ward. Come here and attend this patient immediately.
These are 2 IM loading doses for each buttock.
And write a refer letter also to the medicine department and neurology department.
Yes, sir.
Check her GCS score.
Fine, that situation.
Neck
is under
rigidity, everything you
control.
just notice.
She is not having repeated convulsions. Very good. These are the IM.
People checking, she needs.
She's fine.
Okay. Who are you?
I'm her sister.
Okay, she is your elder sister.
Yes, sir.
Okay, I will tell you. Don't be worried. Don't be panic. Just go to side. I will talk you through. Listen. This is. I want to say something about her. Actually, she is having so high BP, and this high BP causing this type of convulsion. This is our medical term called eclampsia. Due to her severe hypertension, brain oxygen is low down, and the brain having fluid. We call brain edema. For this reason, she is having convulsion, this type of convulsion. We have already given some medicine for control her BP and some medicine to control her convulsion. Now, her convulsion is likely to be controlled, but she need to stay here for 24 hours, and this injection we need to give for 24 hours. And I will call our anesthetist team, our neurologist team. This is a multi-specialty hospital. Here is our oxygen, DC shock machine. This ventilator is everything in our hand. NICU is there. No. If she needed, then I will give it. Otherwise not. Now we will check her BP after few some minutes, and the next part is the the baby delivery. Baby, no. Actually, your sister and the baby is very high risk patient. This is very high risk patient. We need to clearly see this patient. Repeatedly, I will see this patient. But first time we will give some medicine for delivery of the baby. Okay. But if she not responds with this medicine, then we can go for cesarean section for delivery of the baby.
So normal
Yes, may be possible. We will check later on whether the normal delivery can possible or not. If not, then we will go for cesarean section. Okay?
So
don't. No, actually, may be fine, but she is critical condition. Her baby is also critical condition. Okay, this is medical emergency. This is pregnancy-related hypertensive emergency. Definitely, we will try for best. Okay.
This is demonstration of how we are going to collect the urine to test for protein content in it. After sterile catheterization, Dr. Monisha, will you just show, please? We use a sterile container to collect a sample, which will then be subject to a dipstick, which is available to test for proteinuria. We have these degrees from which by color, by comparison with color, by color you can make out how serious the proteinuria is. Besides this, we can also go for 24 hours urinary estimation or urinary ACR. But this is the best bedside method which can use to treat your patient.
But UDP is 3+.
Wow, that is very serious. We have to deliver her and think about termination as early as possible. So to control hypertension in eclampsia, the antihypertensive which is of choice, first choice is labetalol. Labetalol we give at a dose of 20 mg, given slowly. Then it is given IV, and then we are going to check the BP after 20 to 30 minutes, and we repeat accordingly to a maximum dose of 240 to 300 milligrams. The drug of choice for convulsion of fits in eclampsia is magnesium sulfate. It comes in an ampule of 50% strength, that is a 2 ml containing ampule. It contains 1 gram of magnesium sulfate. The magnesium sulfate is given at a loading dose, and along with it we give the maintenance dose as well. The loading dose, it comprises of an IV as well as an IM dose. The IV dose, it consists of 20% of magnesium sulfate, and the amount is 4 gram. So for preparation of the IV dose, we need 4 ampules. Each ampule contains 1 gram, so we have 4 grams of magnesium sulfate. This is diluted in 12 milliliters of sterile water for injection. As you can see, Dr. Manisha is preparing the IV dose. So after preparation, we have a 20% solution of magnesium sulfate, and that is of 4 grams. This is given IV slow over a period of 15 to 20 minutes. Simultaneously, we are going to give the IM dose. The IM dose consists of 5 grams of a 50% magnesium sulfate solution given in both buttocks intramuscularly. And for this, we are going to need 5 ampules for each buttocks. So in a nutshell, the total amount of ampules that we need to prepare the main loading dose is 14 ampules. This is followed up by the maintenance dose. The maintenance dose, it comprises of 5 grams of magnesium sulfate given iron intramuscular on alternate buttocks at an interval of 4 hours. So this is given for up to 24 hours. 24 hours after the last convulsion or childbirth, whichever event is later. While giving magnesium sulfate, you also need to monitor the patient. Monitoring is done of the deep tendon reflexes, that is the knee jerk, respiration rate, which should not be less than 16 per minute, and urinary flow, which should not be less than 100 ml per 4 hours. So that is what we need to give. That is how we are going to give magnesium sulfate.
So we are preparing the MaxSulf dose based on the Pritchard regime, where the loading dose is prepared with 4 grams of magnesium sulfate in 20% concentration. For that, we are taking 4 ampules, 1 ampule containing 1 gram of magnesium sulfate, and a total of 8 ml magnesium sulfate is being taken, drawn in a 20 ml syringe. This will be diluted with 12 ml of water for injection, making it a concentration of 20% of IV magnesium sulfate, which is to be given slowly. So once we have prepared the IV dose, simultaneously we will make the IM dose of magnesium sulfate of 50% concentration. For that we will need 5 ampules of 1 gram magnesium sulfate each. So we are drawing 10 ml of 5 ampules of 50% magnesium sulfate for each buttock in 10 ml syringe. We will prepare 2 such 10 ml syringes for each buttock. The broken vials are disposed in the, based on biomedical waste management, we are disposing in blue container.
Monisha?
Yes, sir.
I have checked this patient already. That is her blood pressure is still 146 by 96, and though FHS is good, and already she having 2 times convulsion, and she is getting oxygen and oxygen saturation slightly low down. Anyway, she needs to send some blood investigations. Have you sent blood investigation? Have you sent?
Yes, sir.
Okay.
Yes, sir.
What you sent? I am telling you what have to be sent. That is the blood for complete hemogram, CBC, urea, creatinine, sugar, fasting HbA1c, lipid profile, uric acid, liver function test, TSH, urine protein already we have done, and we need to 24 hours urine protein. Any possible of ultrasonography, FPP urgently in our radiology department?
Yes,
Is it possible?
Yes, sir.
Okay, or if not possible, because she need to deliver immediately, because her PV already done, but her Bishop score is not good, so she cannot be delivered by cervical, vaginally. So her cervix is thick, so vaginally not possible delivery. So we need to deliver her by cesarean section. I need to talk with her patient party. You call her sister.
Yes, doctor.
Okay. Your elder sister?
Yes.
Says, okay. And your
Is
name,
she
please?
fine now?
Your name, please?
Anisha.
Okay, Anisha, please listen. What is happening? What we are trying to give her treatment. Basically, your elder sister is 38 weeks pregnant lady.
Yes, sir.
And having BP was so high, 180 by 110. Now BP is controlled, but her CTG, that is the baby well-being monitor, is one machine by which we can monitor the fetal well-being.
Yes, sir.
It is not. It is showing not good graphs. Okay. Probably baby is depressing. So I need to immediately deliver the baby, because her vaginal delivery not possible. Her cervix, that is the mouth of the uterus, is not well opened. So I need to deliver the baby by cesarean section.
So baby is fine now?
No. Baby, her baby fetal condition is not good by our documented CTG machine. So I need to deliver her immediately.
Okay, sir.
Okay?
Whatever you decide.
Yes.
And is she unconscious?
Slightly conscious, semi-conscious.
Okay, sir.
Okay.
Whatever you feel best. Kindly save her, sir.
Yes, yes. Don't worry. We are trying our best.
Okay, sir.
I will call neonatologist also.
Okay, sir.
Our pediatrician will be there.
Yes, sir.
NICU is there. Don't worry.
Okay.
I am trying our best level. Okay? Thank
Okay,
you.
sir. Yes, sir. Please. Thank you.
So eclampsia is divided into three parts, that is the antepartum eclampsia, intrapartum eclampsia and postpartum eclampsia. Most common is we see in our day-to-day practice, most commonly we face those antepartum eclampsia. We have demonstrated the drill of antepartum eclampsia also. In this case, apart from the regular management of a critical patient like airway, breathing and circulation, we have to ensure then and there, we have to put the face of the patient on the one side to prevent aspiration. We can admit the mouth gag also. And then we have to do the airway, that is we have to put oxygen. And if the breathing is okay, then oxygen mask will do. And then circulation, definitely we have to check her blood pressure, pulse and all vitals, respiration, everything. Now we have to ensure the circulation with IV drip. Generally, we do the normal saline or ringal lactate. That is a fluid we infuse. And then we'll start magnesium sulfate. Magnesium sulfate is a key drug in maintenance of management of eclampsia. So we'll give IV and IM as loading dose 14 gram. And subsequently, we have to do the maintenance dose as we have already demonstrated. And side by side, you have to send some investigations. That is the investigations of blood and investigations of urine. Previously, we used to do 24 hours urine protein to note the proteinuria. Nowadays, we do the albumin creatinine ratio, or straight away in the bedside, we can go for the dipstick. And apart from the dipstick, we can check her hemoglobin bedside, and we have to check her platelet count. We have to check her, that is a complete blood count, platelet count, liver function test, kidney function test, to denote the situation or the gravity of preeclampsia. That is, if preeclampsia is associated with severe organ damages, so these things will manifest her organ damage. So we have to assess. And another thing is the delivery. That is the termination of pregnancy in antepartum eclampsia, because it is of utmost importance. So we have to see the Bishop score, and if it is not favorable, the cervix is unfavorable, then we should not waste time. We have to go for cesarean section. And if she is preterm, it is below 34 weeks, then we have to administer corticosteroids just before C-section. And after C-section is also, our duty is not over, because she may suffer from PPH and other complications of postpartum. So we have to keep a close look, and we have to continue Maxalf after 24 hours of after delivery or after the last convulsion, whichever is later. That's all. Thank you.
Thank you.
Thank you. Thank you. It was an excellent session. Dr. Runa, you have any comments?
Not exactly, but we have done this. This was our maiden venture. So we also enjoyed during this drill, and it was not done on the real patient. It was a dummy patient. One of our nursing staff, she acted as a patient. So we have done this, and so now it's open for your remark and comment.
Thank you. Thank you. Thank you all for
most welcome,
excellent
madam.
job. Yeah.
Most
Dr.
welcome.
Jitesh Shah, sir.
Yes, madam. Am I audible?
Ramesh, no, Ramesh Haldar.
First of all, I congratulate Dr. Runa Bal madam and her team for successfully conducting the eclampsia drill. All steps of management are explained in a proper way.
Unmute
Not
yourself.
audible, sir.
Unmute yourself. Yes.
Am I audible now?
Yes, sir.
Yes, yes.
Yes. First of all, I would like to congratulate Madam Runa Bal madam and her team for successfully conducting the eclampsia drill. All steps of management are explained in a very good way. We all know that eclampsia is a rare but life-threatening emergency. It's required teamwork, which include obstetrician, anesthetist, staff nurse, servants also. We are learning the management of eclampsia since our MBBS level. But when a pregnant woman gets convulsion in front of us, we all become panic. Inappropriate management can lead to poor outcome. Here comes the role of eclampsia drill. All obstetric units must have standard operating protocol for management of eclampsia, and all obstetric units must conduct regular eclampsia drill at least 3 to 4 months. And while conducting the drill, the senior member should become as a team leader and should assign the role of each member in the team, so that whenever a woman with eclampsia comes, she is managed properly so that we can get a good outcome. Even after conducting the drill, there is a role of debriefing, as Madam has already explained in the lecture, that will analyze our performance, identify gaps, and that will provide the scope for improvement. Thank you.
Thank you, sir. Shall we move on to the next drill, ma'am? Yeah, you're muted, ma'am. Yeah, ma'am.
Yeah, Dr. Haldar has got any comments? He was also a part.
You're muted, sir.
Thank you for joining. And it was excellent demonstration, I must say. And I must also thank the demonstrators, Dr. Mini, Dr. Anuvali Nag, Dr. Sangamitra, Dr. Madhurima, Dr. Manisha, Dr. Anvesha, and Dr. Shaista. So I think they are all there in the audience. But thank you very much, everyone. Let us move to session 4.
Sadhana Gupta, ma'am, would like to say something.
Yeah, Dr. Sadhana, you want to comment on this? You have to unmute yourself. You just IT team, please unmute Dr. Sadhana. Sadhana, please. Shreya. Shreya, please unmute Dr. Sadhana and Dr. Sheila. ICOG team. Sadhana, you can give comments after the 4th session now.
Yes, just,
you can.
Am I audible?
Yes, ma'am.
Yes.
First of all, congratulations, Dr. Runa. And it is always very good to see, always with the all lifetime experience, we always want to look into details. Just I wish to add a little bit, like a emergency ultrasound, especially in antepartum eclampsia, because we can put the ultrasound machine near the thing. So the person, we are sure that what sort of baby we are going to deliver. And the second thing that we say, don't worry, it's okay. To me, any patient who is coming with 180, 100, we will give very guarded prognosis.
Yes.
That this is the thing.
Nothing
and
is
this
okay.
is the disease which is affecting every organ. And we have to be careful, not only during cesarean section, but also in the post-operative way. And yes, then we are taking our best care. So we cannot say, don't worry, because it is really worrisome. And this is the time that we under like a very early decision for cesarean section, because whenever patient has fit, we get the compromised CTG. And once the fit and blood pressure is okay, the fetus is also improved. So we can, if it is preterm, we can give steroid and we can give this all maxillary protection. So this is my 2 comment, that the very guarded prognosis, so that we and they are ready for it. And the secondly, emergency bedside ultrasound is the very common thing we can do. And the third thing about the timing, like a immediate reaction to CTG during conversion. So these are my 3 comments over.
Thank you, Dr. Sadhana. We are discussing about the methods and drills, how we can perform and train our staff. And your comments are well taken. Thank you very much. We are moving towards the last session, that is on maternal collapse. And I invite our next team, that is Dr. Rajashri Katke. Can I have her CV for the people? Because I know her, I can tell her a lot about her. She's a renowned obstetrician and gynecologist and surgeon par excellence, professor and head of the unit, and former HOD of the Grant Government Medical College, Mumbai. She's the researcher, author, many 100+ publications and many awards to her credit. Next is Dr. Shikha Seth, who is a professor and head of the department and dean at AIIMS Gorakhpur. So she's also a part of this next demonstration on management of maternal collapse, and we have demonstrators Dr. Vishal Wagmare, Dr. Rucha Gungane, Dr. Kanchan Jadhav, Dr. Shubhangi Navrange, Dr. Trishali Dongre, Dr. Siddhanti Ramteke, Dr. Pragati, and Dr. Gauri. So over to Professor Dr. Rajashri Katke. And Dr. Shikha Seth. I can see her also. Namaskar.
I'm really. Can I say something?
Yeah, I can say first you can demonstrate and then you have your
okay.
comments.
Yes. Okay.
Shreya, could you play the video, please?
Yes, ma'am.
पूजा आप ठीक हो? पूजा सिद्धांत they call Dr. Rucha, Dr. Vishal. पूजा
Dr. Rucha, Dr. Vishal, patient has collapsed. Please come forward.
Sir, there is no pulse. Sir, no breathing.
Activate code blue.
Hello, Dr. Kanchan ma'am, Dr. Shubhangi ma'am. Code blue, please come to ward.
And there is no pulse and no breathing.
Yes, we need to start CPR for the patient.
Call Dr. Katte ma'am immediately.
Hello, Dr. Katte ma'am. One blue. Please come to ward. Is there a person? No.
What has happened? What has happened?
One patient had collapsed in the ward. There is no pulse. We have started with the CPCR.
Okay, so now if the patient is like this, the patient is, she is collapsed suddenly. The most first important thing is that give a right position to her. There has to be a lateral displacement of the uterus, which is the Dr. Vishal is doing it. And there is a chin tilt and this ambu bag ventilation. Either you can do with the first hand technique or if you have an assistant, there is a two hand technique is there. And she is giving the ventilations. So basically the first thing is that whenever the patient gets collapsed in pregnant women, it is very different to even to get away to open the airway because of the pressure of the gravid uterus and the enlargement of the breast is there, laryngeal edema and all. So one has to be very trained in that, and Dr. Rucha is doing very properly in this thing. Dr. Kanchan is giving the CPR. CPR is very different from a non-pregnant woman to a pregnant woman. So in a pregnant woman, because of the splinting of the diaphragm and the enlarged breast and all, so it becomes very difficult. So what we have to do is that take two hands, how the Kanchan has interlacing the fingers. It should not do with the fingers, but she is doing rightly with the palms. There has to be a 30 compressions with 2 breath ventilation. It should be perpendicular to the chest wall, and she is giving it the right way. Kanchan, if is there any response? We will check the pulse, the BP in that. So pulse, BP, oxygenation is there, IV fluid is started in this, and then you are supposed to do for the chest compressions, and the ventilation is there. Fetal heart rate, we should always see the assessment of the fetal well-being. So fetal heart rate, how is Shubhangi? Fetal heart rates, they are positive? So that means the fetus is still alive in that. Any response is there with the pulse and the carotid? If there is no response,
please assess for salpy pulse from that side.
No pulse or no radial pulse and no pulse on the mouth.
Okay, so after 2 minutes of the CPR, always you should do the assessment with the breathing. If she gets a good respiration, if the heart or the pulse, you palpate the pulse, and if it is palpable, then that patient is responding to your line of treatment, and one should treat with the availability of the intensivist, physician and all. At the same time, you are supposed to treat what the cause is there in that. But sometimes you don't get that every patient is in the ward and all. Sometimes at the social places, if they get collapse, then the person should be who are trained on there for the CPR also. They can immediately shift such patients to the nearest hospital and to give the CPR for that woman. That is very important in that. The second important thing is that what they are doing is this, with the lateral displacement, the supine hypotension or the pressure over the inferior vena cava, it is being released. So it will give more cardiac output. So there will be a brain sparing because she has done the head low also and the chin is still. Suppose there are so many secretions are there, then you can suck the secretions and all in that. This CPR, we are doing it Kanchan is giving the continuation of the CPR. Sometimes one person get tired of giving the CPR, then another person is there. If you have availability, they can give the CPR for such conditions in that. So if there is no response is there, then it is an alarming sign. With the CPR, the management of the defibrillator is there, and drugs has to be given in that. And Dr. Shubhangi will explain about by giving how to give the defibrillators in this.
Please clear the fluid. I have to apply the defibrillator. Clear now.
So now Dr. Shubhangi is giving, applying the defibrillator, and you can apply it. This is very important to revive the heart activity. And if she has doing with the biphasic, it goes to the around 150 to 360 joules. You should use that. And if it is monophasic, then it should go for around more than 360 joules of that. And how is the response, Dr. Shubhangi, of that?
She's not responding yet with the
Okay, so let us start with the CPR and again give with the this thing.
Okay, and clearing the fluid.
So again start with the CPR, Dr. Kanchan. The rate has to be 100 to 120 per minute. 100 and 120 per minute with lateral displacement, and you can give the ambu bag ventilation 30 raised to 2 ventilation. This is very, very important. We have started with any pulse is there? Shubhangi?
No pulse is there.
No pulse is there. So we are continuing with this. We need to have now advanced life support. Yeah, at the beginning only we have started with the circulation. We have taken 2 wide bore green color these wide bore cannulas to maintain the circulation in that. The CVP line is also taken. Sometimes some patients you don't get the pulse to put a cannula, then you can do the CVP or the cut the veins and you can put the this thing cannulas in that, because the maintenance of the circulation is very important in that. You can start with the crystalloids, arrange for the blood and blood products whenever there is a hypovolemia is there, hemorrhagic shock is there. That is very, very important in that.
Already given the fibrillation shocks. So after the third shock, if the patient doesn't respond, then we have to give injection amiodarone. That is 300 mg IV bolus injection we should give and see for whether the patient is responding or not.
Okay, so now the patient is not responding to the advanced life support also, and I am hearing the fetal heart rate well. So Pragati, you just asked that relative we have to perform because 5 minutes has been gone there and there are still fetal heart rate. Patient has not responded, so we will take the decision of the perimortem cesarean section, because this is around 37 weeks baby is there inside and baby is live in that. So we can do for the perimortem cesarean section. For that, the consent is not needed. If the relatives, you can explain to them, you don't need an anesthesia for that. Sterilization, just put a sterlium or the betadine if it is available in that. Take the sterile handle in that, and take a liberal incision to deliver it fast as in the midline, and dissection of the urinary bladder, and we can dissection of the urinary bladder, and you can deliver it. You have to deliver it as fast as possible. Cut the cord, leave the placenta like that in that, and then, but at the same time, when we are doing the perimortem cesarean section, we have to be very careful that the baby should be immediately given to the pediatrician, and the resuscitation should be continued for that. This is, we are saving the baby, but it has to be, the decision has to be taken within 4 to 5 minutes of that, and the procedure has to be pretty fast in this to save the baby's life, and for the mother's life, continue the again the resuscitation in that. So I think with this, because the pressure over the heart and it has been come out of it, and this pulse is, I think she is responding now. I think she's getting the this thing. Yeah, the pulse is coming it up, and very good. And patient is responding in that. And this patient, we have already called the anesthetist to intubate her, and the intensivist. We arrange the blood and the blood products, and we arrange the bed into the intensive care unit, and with that the suture of this postpartum cesarean section, we are sending this patient to the ICCU, and this patient is alive with the effects of this one. So it is very important to, the first important thing is that you should form a team in your hospital, whether it could be into the institutes, definitely there is a team is there, but in the nursing home also, whatever your ward by staff sisters and all, there has to be a put a alarm bell, or the WhatsApp group should be there, or there is any communication, whatever mode is there, you can start with that. And this is with this here, the time is life for the patient. Every point of the microseconds also it is needed in that. And what Dr. Rucha, given the position with the then lateral displacement is very important in that. So there are 4 or 5 things which is very important we should look in that. There has to be the lateral displacement to prevent the hypotension, and to prevent the pressure over the inferior vena cava is very important, as Vishal is doing very properly with the both the hands. It should be with the upward and towards the left side. This is very important with that, how Shubhangi is explaining in that, how the pressure has been released in that, and it has been increased the cardiac output in that. So the second important thing is that whenever you are doing it, there has to be known facts of that, where the Kanchan has very nicely explained in that, where if you can see that a pregnant lady, there is a laryngeal edema is there, and because of the effect of the progesterone and pregnancy changes, and this change, with these changes, there will be difficult intubation, the enlarged breast will be difficult, and splinting of the diaphragm, it will be a difficult CPR. So Dr. Kanchan has very rightly explained how it should be done with both the palmar, this thing, interlacing fingers. It has to be perpendicular to the chest wall, and it has to be only 5 to 6 centimeter. Do not give more and more of the things, and there will be a fracture of the ribs, or some of the bone spicules can go and damage to the heart in all. Don't get panic. First thing is that is the most important thing. And Gauri, Pragati and all, they are immediately they have responded, call for the seniors. These are the junior team, but they have done a wonderful work in this, I think, maternal collapse drill and all. Immediately Rucha has come. She has nicely ventilated this patient. These are the very important thing. The way they are coming it, they are doing it technically very correct. With the first, she was first single, so she did with the first hand, single hand this ventilation, and after that Vrashali has joined to her, and she has helped into the ventilating the patients in that. So Gauri, has timely seen the patient, and she saw the responses. The initial response is very important, with the patting of the shoulders, asking the patient. That is very important. If she shouldn't have gone there, then all these team blue couldn't have, and they have very timely called our senior residents, Dr. Kanjan, senior lecturer, or Dr. Shubhangi, and all the team has arrived it. And definitely with the availability of the these defibrillators and all, we have done the things. The continuously you have to the monitor. Continuously you have to monitor. I don't go in detail of that. We have the emergency, modified emergency Mio scoring is there, and in that basically you should see for the response of the patient, ventilation, breathing is there, appearance of the pulse, BP is there, and we have already applied this patient with the 12 leads of the ECGs, and the monitor is there, and with the monitor the response we are just assessing the response. Dr. Shubhangi has explained the emergency drugs very properly in that. Siddhanti was working and helping to take the two wide bore needles and IV setup and all. Continuously BP monitoring is done by the Pragati, and this is the team. They are helping, arranging the drips and giving everything in that. Every minute thing contributes to saving the mother's life in a maternal collapse, at the crisis of the life in the mother's life. So this we have timely done. Oxygen saturation, if suppose you have the things, then oxygenation with the ventilation. If you have intubated it, go for the high flow oxygenation. If you have 10 to 15 liters per minute, it has to be according to that. And we should establish the breathing, the circulation, go for the crystalloids, give for hemaxil if it is needed. Blood and blood products has to be there. We should rush if there are the 4H and the 4Ts. We have to work in that. One is the hypovolemia. It may be because of the dehydration or the hemorrhages in that. If suppose there is a PPH, abruption is there, in those cases you are supposed to give the blood products, and that will help to this. You have to push for the management of the PPH and all. That drill is different, so we have not taken in it. And if suppose she has eclampsia, even you treat the convulsions, give for the magnesium sulfate, see for the toxicity and all. And we have to be see whether patient is responding or not responding. If with your initial basic life support, if she responds, she should go to the intensive unit, ICCU, or if you have a HDU, and it has to be a teamwork with the anesthetist, the intensivist, physician, and the obstetrician and the pediatrician. So it is a teamwork always, and it gives the good results of that. And also when you are going with this monitoring, so all the things has to be monitored. See for the fetal heart rate. If it is alive, she is not responding, within 4 minutes we have taken the decision of that. And this is the trolley. This is the trolley where you don't need for the periportum cesarean section in that. This is the Doyen's retractor. These are the artery forceps state. This is the BP handle, and the Caesar is there, and you can take it out the baby and hand over to the pediatrician in that. So these are the things where you can go ahead with that. So one is that this is the we know that it is always teamwork and interventional. The interventional or the intensive care unit is very important in that. We just see for the Q-SOFA score when she is appearing in that, and the treatment is to be given as Dr. Shubhangi told about this, the sodium bicarbonate. Then there is a hypokalemia. You should give the hypocalcemia is there. Then you can treat with this. Hyperkalemia is there, then you can give with the calcium gluconate and all those, everything we know that about this. And if there is a toxicity is there, abruption is there, immediately you deliver the baby. Main important thing is that with resuscitation, if you take it out the baby also, that releases the tension over the heart. Or if there is a abruption is there, if there is a toxicity, it goes from the and it relieves, and it gives the better amount of these things. So don't get engrossed only with the support in that. Take a decision, what is the cause which has come to the which have come to the maternal collapse of this this patient. One condition in the labor ward, it is very, very difficult. It's like a nightmare to us, is the amniotic fluid embolism, pulmonary embolism. In that, suddenly patient gets collapse, sinus and all. So the trained people with this blue code system, they will immediately handle with the oxygenation, giving with the fresh frozen plasma, the recombinant factor 8, and all required things, because even with the amniotic fluid embolism, with good treatment, we are having around 40 to 50% of the success rate. In the centers worldwide, it has been documented in this. And the one more thing is that whenever they are delivering and she gets collapse where there is a acute inversion, when there is a short cord is there, the placenta is adherent to the fundal, or too much of the pulling, or Credis expression, or the placenta with attached to the fundal fibroid, that can pull the placenta, that can pull the uterus turn outside, and it will give the inversion where there will be the neurogenic shock and the hemorrhagic shock. So we have to be very, very careful in that. The second important thing is that even sometimes, very rarely, but the patients, they do come with the anaphylaxis and the drug reactions. In that, immediately you should start with the giving the steroids, then basic life supports, ventilation, drugs and all, and patient can revive if you catch it in a proper way in that. Then other cardiac disease, eclampsia, hypertension, and all these diseases with the tamponade and all trauma. So all tension pneumothorax, all these are the, you have to diagnose it and treat the conditions. And for many of these conditions, they have a separate drill. So we, our team is very nicely concluded this, I think, this drill, and I'm really thankful to ICOG, Dr. Sheila Mane madam, then I'm thankful to Dr. Pratik sir, Dr. Sadhana Gupte ma'am, and this Rahul. So for making this to happen, our patient is Pooja. Very nicely she is revived now, and after the second day's round, she was very happy, and she was very good in that. So this is the thing in that. So she is a doctor. Pragati is there. She is our junior resident. She is very nice. Dr. Gauri is there. She just joined 1 month back. Dr. Shubhangi Naurange, she is our assistant professor, senior, very, very well experienced and all. Dr. Vishal is our CR, Dr. Vishal Wagmare. Dr. Kanchan is there. She is SR, and she has experience more than, means after MS also for 2 years. Then Dr. Siddhanti joined, and they have done very nicely. Dr. Vrashali is there, and they are doing very nicely in that. And Rucha is there. She is also our junior resident, senior resident, JR2, and all of them, they have done a very nicely demonstrated. I hope you all like. Myself, Dr. Rajashree Katke, a professor, Grand Government Medical College, and former head of the department, Grand Government Medical College. I hope you have liked it. And she is Dr. Pooja.
So Pooja.
हाँ पूजा, गुड मॉर्निंग, कैसी हो, कैसे लग रहा है? बहुत अच्छा लग रहा है ना, बच्चा भी बहुत अच्छा है। हाँ, अभी थोड़ा सा वीकनेस लगेगा आपको, लेकिन हम लोग आपको ट्रीटमेंट देंगे उसके लिए भी, और बहुत मुश्किल था आपका ये करना है, तो वो सब करके हमें आपको अभी बाद में डिस्चार्ज करेंगे। बच्चे को देखा ना जाके, अभी बच्चे को दूध भी पिलाना है और अच्छे से फिर ये करना है। हाँ, कैसा लग रहा है अभी आपको? टीम ने हमारे सारे, कैसे आपको लगता है?
थैंक यू सो मच, टीम के कारण बहुत अच्छा हो गया, मुझे बहुत अच्छा लग रहा है।
So at the end, this is the condition where you will get in the obstetric rewarding one, where you are dealing with the two lives of the patient. One is a patient, the another one is a baby's life. So saving two lives with the efforts, it is a very good condition, and one has to be very careful in that. But here I would like to her smile on her face gives the immense strength to us to work for the patients. But one important thing is that while doing all these things, we have done a very important thing is that the senior resident Dr. Vishal and all, immediately they have written all the things on the paper, at what time she has collapsed, what drugs we have given. So documentation is very, very important. We do so much for the patients, but if we don't document it properly, so clinical governance is the important key in all these things. We always do everything for the patient survive. Sometimes if the patient doesn't get survived, and if you don't write our notes properly with the date, timing, what you have given and all those things, then it becomes very difficult. We are here in the era of the Consumers Court and the medical legal this thing. I have been on the part of the maternal death audits also and the committees where we have done the inquiries, where we see that the doctor has done a very good treatment to them, but unfortunately there were some lacunae to have in that. So we have the checklist there. So that checklist is also very important to show them. So in the documentation, the proper documentation should be there. If the death occurs, the incident reporting is very, very, very important, and that has to be with the authority. And third is that debriefing is very important. Sometimes if the patient remains alive with the post-traumatic disorders, that is also very important. So whenever they get psychologically disturbed, even with the clinical, with the family, the patient and the clinical staff sign in that, with the help of the professions, counseling and the treatment is needed in that. So my humble request is that you do everything to save the life, but to save yourself, do the proper documentation and debriefing with the clinical governance. That is the take home message from all our team is in that. And we should celebrate all the things. We have got the success in this patient with the teamwork and activation of the code blue. For documentation, debriefing and the clinical governance, I have explained from our behalf of team how to go ahead with that, both at the national and international level. People are practicing about the documentation to avoid the medical legal issues. So this is the mock drill checklist, code blue. So this is this thing. The first point is that first responder responsibilities. In that we have just mentioned it whether we have done or not in that. So first responder responsibilities has done very clearly. The second responder responsibility is also very important in that, and they have done it very properly with the bring the crash cart trolley and other emergency equipment, secure the backboard under the patient. Here it is a very hard surface, bed is there, but suppose if you don't have the bed in that, then make it on the hard surface. And if you want to give a head and head to toe tilt off, then it should be 15 to 13 degree to the surface of the board, and there has to be a lateral displacement of the uterus in that. Then ambu bag is also very properly done in that. That has helped into the mentioning. When core team arrived, we have my lecturer gave me the properly history what has happened in that. I examined the patient. Then we have seen there was no response in that. So if no other responder available, first responder will be go for the person of the core team members. So we have followed this also. Took the electrode, and Dr. Shubhangi has demonstrated how to give the defibrillation with the instrument and all. Then inserted large bore cannulas, Pragati, Gauri, they have already secured with the green color. We have the 18 gauze number, this 16 to 18 we have a green one, not the gray ones in our hospitals, I mean. So we have used that. CVP line was also established in that. Later on the anesthetist also has come to, if it is needed for the intubation when the patient is very in unconscious state in that. So then sure calls for arranging the ambulance and all. I have already explained to whenever such patients, they are not in the hospital and all, you have to go with the cardiac ambulances. And we have in the government, state government of Maharashtra and the government of India, it has given the ambulance services very properly. And in that, some of the cardiac ambulance, it has a monitor and the doctors, accompanying doctors also in that. Nurse in charge responsibilities, we have already explain with our nursing staff in that, so what they are doing in that. The last one is the tracking the documentation. The documentation is very important. We have written all the papers. We have written all the notes with the date and time. Date and time is very important in all these things, because the time is important. When she became collapsed, when she was unconscious, how much CPR is done, how many minutes we have been given, whether it has given in time and all, and the perimortem cesarean section also, whether it has been done. So I have personally checked. There was a fetal heart rate, and till 4 to 5 minutes she has not responded, and then we have taken the decision. Even we have explained to the relative also for that, just as a precautionary measure, but you don't need any consent for that. You don't need anesthesia for that also. So that is about this. The documentation it saves the piece of the paper. It saves you even after the 10 years, 15 years in your life, whenever there is issues with the medical legal or the case goes into the consumer's court in that. So that is very important in that. We have all trained all the people to with the emergency warning score system. In that all the parameters are there. So right from these ventilations, then these physiological parameters, respiratory rate, oxygen situation or saturations, and all temperatures, systolic, diastolic BP, per abdominal examination. After this thing, whether there is a bleeding is there, or there is the height of the uterus. If suppose there is a atonic uterus, then the flabby uterus, condition to condition it becomes very different in that. But the basic things is the vitals, which is very important in this case, whether she is responding or not responding in that. So with our treatment, it has been responding in that. Then catheterization we have seen immediately when the patient has gone. Then Siddhanti has put the catheter to the patient, and the urine output after that it was coming it out. So these are the things. For that, when such patients come to us, the team has to be activated in that. That is the importance of the code blue, or the inner core hospital team, or your nursing home team. Patient is there. Even such patients come to you also. Give the basic life support and then transfer the patients with the doctor, with the IV line secured, and in a cardiac ambulance. Don't, when such patients come to you, even into the nursing home, don't deny the basic or life supports to them, because medical legally also it is not correct. We are supposed to do these things, and then you transfer the patients to help to save the life of the woman also, and even to prevent the medical legal complications or issues to us also. With this, all over India, if you are seeing that most of the states, they are doing very well in this, and that's why we have reduced the maternal mortality rate to 88, and in the Maharashtra, Kerala, again it has been improved, decline into the maternal mortality rate. That gives the idea that most of the states, and even in the UP also, they are trying very hard to come it down. This contributes to the awareness with the obstetrician and gynecologists, the government, the state government, and the government of India. Here, I would like to, if you have the facilities of the anti-shock pneumatic garments, then you can, with that suit, you can ship the patient to the higher centers, because that with the legs, it gives all the blood supply from the non-visceral organs to the visceral, and it gives the heart blood supply more towards the heart and more towards the brain in that. That is what the important thing is, and we have to work for it to save the mother's life and the baby's life, so that we will reduce the maternal mortality rate in 2030. The SGD goal is it should come down 2030, and that will help to all of us. So training is very important, and updating, continuous medical educations, updating and webinars are very important. And thank you very much. The ICOG is doing, and the ICOG chairman and all, Dr. Sheila Mane madam and all, they are doing very good work with this Dr. Sadhna Gupte ma'am and Dr. Pratik Tambe sir and all the team. They are doing it, all these recorded drills, webinars and all, so that we can educate many and many people of the country to save the mother's life. Thank you very much.
Oh my God.
Thank you. Thank you so much.
First, I would like to thanks to Dr. Vidya Thobi, madam. Namaskar from here. I was not aware of the most of the things. Thank you, everyone. And this thing, and this was actually this is the topic which includes most of the topics in it. So it was it is slight lengthy, but it is very important. If I don't take some of the topics, then it doesn't justify the this thing, I think, drill in it. So the team has done very well. So what 3-4, because we have explained everything, I don't want to take much of time on my views on it. I would like to hear from all of you and take your guidance on it. Because but
Yeah,
the
yeah.
most
Thank you, Dr. Rajeshri. It was really a wonderful play, and you explained each and every minute demonstration was great. So, Dr. Shikha Singh said is there. I want her comments.
Good afternoon, everyone. Thank you. First of all, I would like to say thanks to whole of the ICOG team for giving me the opportunity. And this is really a very important section which has been covered. And simulation is really an important aspect that every student, or especially the PGs, should learn, because these emergencies, they come all of a sudden, and often the people, they forget because the sequence of the events, sequence of the things is very important. They have to go one by one. So the drill which has been shown was excellent. Madam explained all these pinpoints, the minute things. But because, as Vidya ma'am said and the Ashok sir also initially said, I will just most of the things were covered, and it was a well demonstrated drill. But the few things which I must say, as this program was basically as I personally got to know, is to understand how the drills should be conducted and how the PGs should be learning.
Yes.
So the more of the task of demonstration should be like that. The thing was that the collapse part was identified immediately. It was very well demonstrated. Then the code blue was initiated. That was all very well done. But the third aspect, when the things were being done, the patient was being managed. So the drills have usually a particular thing which has to be followed. So I just want to mention earlier drills, most of them, they followed those part that the student or the PG who is conducting the thing has to enumerate, say it loudly, the clear instruction. The other person should say that I have understood, repeat it. And then when the task is complete, that small section advice or the instruction is completed, the third person or the person who has conducted it should say that I have done this, so that whole team knows. So this is a very important aspect of the drill, so that everyone knows what is actually being done. And the fourth person who is documenting should be immediately document the things. And in the case of collapse, because it is a very life threatening kind of a thing, we have only few minutes. Most of these drills, emergency obstetrics, are minute based. So every minute one should give a timer that 1 minute has completed, so that all becomes much more alert. Yes, इसमें तो जैसे ही CPR करते हैं, every 2 minutes we have to check the things whether our effects are there or not. So this is all what I just, otherwise it was a complete task. Madam has given all small points. And one more thing is, FHR we usually don't go for, because whatever, even if we go for a perimortem cesarean section, it is just for the revival of the patient. We usually don't as maybe the others have their opinion. Personally, on those 4-5 minutes session, we just don't listen for the fetal heart. It doesn't matter. It is it is the emptying of the uterus, because it is pressing, it is reducing the blood flow to the heart, and that is more important. To improvise the respiratory efforts, or the resuscitation efforts, whatever the obstetricians or the anesthesia team is doing. So the emptying of the uterus helps improving the resuscitation efforts. That is the more objectionable. Yes, of course, we often, in 50-60% of cases, we get a live baby also, because that's the thing. So this is all from my aspect. Excellent performed, and all minute things covered by madam. Thank you. Thank you very much.
I think with the fetal heart rate, I think before doing, if there is hardly there is a few seconds to see that, it is always better. So you can expedite. If you can save the life, that is also very important in that. And every minute they were checking and
I
documentation
think
because the camera has not covered so
somebody
many
has
things.
asked about the medico-legal
Yes.
aspect of
Yes.
it.
Yeah, yes.
But I think in emergency, we
Yes.
have to take the decision. You keep
Decision.
informing them, okay?
Consent is not required, she has told.
Yes, I told
But you have
consent
to
is not
inform
required.
and I think communication. Yeah.
Communication, I said very nicely, because there was one case in that only it has not been told to the patient's relative, and then there was the objection of the patient's relative. So I have told specifically that consent is not needed, but you can explain to the patient so that they are a patient's relative, so that they are aware that these things are to avoid the medical legal complications.
Better when we are explaining also.
Yes,
better to
always,
take
always.
a video.
Yes, yes.
Because
Yes,
tomorrow
yes.
they will deny.
हाँ वही बोला मैंने भी. I said
Video consent.
And you said about that your success rate, So how many cases, I mean, once again, I would like to ask, I think I missed it. In your institute, how many cases were managed, Dr. Rajeshri?
Ma'am, there are so many and reviewed around, we have a very good success rate around, you can say around 60-70%, unless there is an amniotic fluid embolism, but otherwise, most of the cases they are coming referred to us, and sometimes there are many cases where they have been collapsed into the labor ward. This drill, as we need a large space, so in the ward VIP room, we have this thing, we have recorded there only.
Drills you must be conducting on a mannequins or simulated. You have
नहीं मैम, but
simulators.
she was ready. She said कर लेते हैं. तो अच्छा है. She acted so well, and she was very happy also. So it
Madam,
was
as
looking
Dr.
like.
Pratik had joined.
Yes, because now time is running short.
Yes.
So may I request Dr. Ramesh to give his remarks and then
Yes,
Dr.
yes.
Sadhana,
Ramesh
madam.
wanted to give, but he did not unmute. Now also he's not unmuting.
Dr. Ramesh Haldar, please unmute yourself.
May not be possible, Shweta. I think
you,
the
Ashok
backend
sir.
team.
Shreya, you have to unmute Dr. Haldar.
Ma'am, they are closed.
He's a
Please
co-host, then
unmute.
why he's not
Yes,
unmuting?
now he's unmuted. Yes. So
Ah.
please, please. We are waiting to hear you.
Yes. I want to say something. That is the leg rising was needed first time during the collapse stage. And next is the, as early as possible, call to anesthetist, cardiologist and medicine.
Sir, please.
We
So
have
we are,
called them.
as I told in the initially introduction,
drill.
we are not worried about the scientific content that we can discuss somewhere else. Here we are talking about teaching learning methods. So if anything on the drills or anything on the simulation, then please give your inputs.
Leg rising was the first. There was no leg rising in that case.
So leg raising and all these are the components that we are not, we want to demonstrate that part, but
But
we
it
are
is
not going to
understood.
discuss that whether leg raising is important or not. That
Understood.
can be discussed in any other platform. Dr. Sadhana, madam, please.
Sadhana ma'am.
One thing, just I want to say one thing only, and hearty congratulations, Dr. Rajeshri, Dr. Shikha, and Dr. Ashok, who is really giving us a deep learning insight that despite of perimortem cesarean section, and I think the word we should change in our this thing method, resuscitative is taught me. So
Yes.
that takes the question out of it is a live child or dead child,
Yes.
and it takes a little bit medico-legally safer. So resuscitative is taught me.
Madam, that is different. That is
Thank you.
That is all right. Yes, we agree to that. But yes, but that is not our agenda today. Any other comments? If anybody wants, Dr. Lakshmi, madam, you want to say something?
Everything is covered, I think.
I think
Yes.
we have it has covered most of the
Yes.
points
Dr.
in
Lakshmi,
that.
anything?
And one
No,
important,
no.
I would
They
like to
covered all the points.
ये
Yes.
एक ही बोलती हूँ because there are too many, I mean, people to do the things, and if everybody gives the voice, then it would have been a cumbersome. So we decided as a team that one will explain and other will do it.
So
No,
yes,
no, it was
that
excellent.
that is important.
Otherwise,
That
crowded, and somebody speaks, and then it
yes,
won't
madam.
never synchronize only that.
So that is what very important in the drill when we want to do the drill to demonstrate and to give the students a message. It is
Yes.
important first that we select the topic. We decide who will play the what
Yes.
type of role. So role defining is very important,
Very
and
important.
then each individual should have a definite statement. What is their role? What will they speak? And whatever they will speak, it will be very clear in terms of understanding. So these are the important components of drill, where each and every part of the team will be having a defined role and what they will be doing by their action or by their verbal statements. So everything has to be in coordination way and it has to be understood by all. So that is why in some of the drills we always say that if one person has said something, suppose doctor has given some instruction to the nurse, so nursing officer should repeat that instruction, that what she has understood from that instruction, and then she should follow. Then it should be followed for the, like suppose a doctor says injection 2 milligram to be given IV. So nurse should first decide that injection such and such has to be given 2 milligram IV. Then she should administer, so that doctor also understands that whatever he has told is correctly understood by the nurse. So these are all component of drills which has to be really understood by the teacher. Then only it has to be uh, undertaken as a exercise so that students can learn it in a correct manner. Yes, scientific content is important, that whatever you want to convey in a correct manner, that should be as per the theory books or as per the practical knowledge, whatever we want to convey to the student in that topic. That is a different story. But here we are more emphasizing on the method which has to be adopted to convey or to impart the knowledge to the student. And these are the different ways of imparting knowledge to the students, probably by knowing the drills, by showing them, and by that we give them more chance to accept that. So rather than giving a didactic lecture, it seems to be interesting for the student also. And we have seen that once we have done the drill or we have done the exercise, after that it is very important to review whatever exercise you have done. So we have to keep some independent assessor also of the drill or the exercise,
Observe.
2 or 3 assessor or observer, and you can, those people will give you independent observation that what method or where your team member have gone wrong or where they can improve in their presentation, so that your drill will be better next time. So these are the few components of drill one has to understand. So if you have any comments, we can wait for your comments. Otherwise, we would like to close the session.
There are many comments in the comment box, and everybody has congratulated our program and they have liked. And this time, I think there was 226 and 236. I think maximum people they joined this Odyssey, means the teachers program, and they loved all the drills. I think you can also start doing at your institutions wherever you're working. You start doing these drills. These videos and this will be available within 2 weeks on Dr. Sheila.
Yes.
They
2
will
days.
be available.
2 days, madam. Within 2 days,
Yeah.
it will be uploaded on the ICOG
Uploaded
website.
on the ICOG website. Please visit. I encourage everybody to increase, apply for fellowship for ICOG, ICOG fellowship, and it will be given in
We
Bangalore.
are starting now.
And I think Dr. Sheila wants to
yeah.
announce that about it, and I will then give a vote of thanks. Sheila, you wants to say something?
Okay, thank you all. I think it was really excellent, and if by observing this, at least they know the steps now. Now I won't talk much about it. Tomorrow we have a Guru Mantra program at 4 o'clock. Dr. Duru Shaha and Dr. Balamba Madam from Hyderabad are the speakers, so please don't miss that opportunity. I'll be sharing it in all the groups. I think that is my main job. Now, whenever I am free, I'm just Lakshmi will know that
We have
whatever
to do
best
that,
you
Sheila.
can do, you go on spreading the message. And I'm happy that so many people have joined. So I wanted to finish this Odyssey and then send Guru Mantra. People get confused.
Yes, they get confused.
But tomorrow, please join. And as Dr. Vidya mentioned, we are going to start credit points even for all the programs now. Every program we are starting, Lakshmi. That initiative I have taken. We are giving points to others and we are not giving for our own programs.
It was discussed so many times in GCM.
No, I told her because the people are
Vidya told me.
collecting
So we have started Vidya now. For every
Great,
program we are
great.
going to give.
Thank you very much.
So, and again, if there are residents here, I want to tell you that 24th we are starting our Gurukul program also. You will get the details very soon. Dr. Ashwath is the convener. That will also happen. So thank you all for being there for the all the drills and definitely, as I told you, it will be of helpful for each and everyone, and we will definitely try to save more and more mothers by this.
And
Thank
thank
you.
you, Vandana, also.
Yeah.
She was in contact.
Arey wow,
Hi.
Vandana.
No,
Very
I'm
good.
giving
That I told her
Vandana.
official Thanksgiving I am giving.
So this week, yeah, because yesterday I had Jogi, today I have Odyssey, and tomorrow I have Guru Mantra. But still, I'm so happy that so many people have joined.
He is always on
Great.
Sheila is on go. Yeah.
Vandana,
Thank you so much
Vandana
for the
said na,
opportunity.
why they joined.
Thank you,
Yes.
Vandana. Thank you,
Excellent
Ashok Kumar. And
I will be giving official thanks. Thank you once again, all the delegates, all the faculties, all of you who have joined this Odyssey for Teachers. My deepest gratitude towards Dr. Ashok Kumar, and foremost who is entrusting us for responsibility of organizing this webinar. Thank you, Vandana. She is actually backbone of this program always. I thank her from my heart. I thank our ICOG whole team, Dr. Sheila Mane, Dr. Pratik Tambe, who has joined sincerely, and others also, Dr. Parag Binimale, Dr. Lakshmi Srikhande, Dr. Sadhana
If it is
Gupta.
Dr. Vidya Thobi's program, I have to join sincerely.
Yes,
But
always.
it was our drill also.
Yes. No, always he joins. So all our esteemed faculty for fruitful discussion and feedback, and thank you for the video recording, the IT backup also. So thank you very much once for everybody. And we also need the feedback from the audience. What type of things they really enjoy? I just wanted to know from them also. Please write to the ICOG. Give your feedback to the ICOG so that we can improve our programs like next time onwards. So thank you. Join tomorrow again for Guru Mantra. Thank you very much.
Thank you. Thank you, everyone.
Thank you.
Thank you.
Thank you, Ashok sir.
Thank you.
Thank you, Ashok.
Bye. See
Thank
you
you,
tomorrow.
Ashok sir.
Again, it is a dream of Dr. Ashok Kumar. Thank you.
Thank you. Thank you. Good.
Thank you. Have a nice day.
Very nice.
Thank you.
Bye.
Should I stop the recording?